It was all amazing.
Yeah, you need to speak.
All right, we're right at 9, but I want to be respectful of time. We have a full schedule. So welcome. I'm glad that y'all are here today. We've got people online as well, so a couple just housekeeping things for you to know. We will move. I did unmute.
Okay, sorry, not to interrupt.
I hope online you can hear me. So we will move through presentations pretty quickly. We have multiple ones today, but if at any point you need a restroom, you can just walk out the door, go to your right, and that's in our hallway. There are restrooms. We'll have small breaks between each presentation, but in case you need those. I think those are the main things. You've got handouts here. Any handouts that we talk about here in the room, we will be emailing to everybody online. So be looking for an email coming out. We are recording this as well. And once that recording is up and posted, I will send out an email letting you know that it's up and available as well. So today we're very excited to have Dr. Wojcicki here. She's one of our fellows here at the center, and she's going to share with us first. So I will hear you.
Are we sharing?
Oh, I don't think so. Okay.
No. Yes. Perfect. All right, so hopefully everyone can see that on Zoom. But like Sarah was saying, I'm Dr. Wojcicki. I go by Dr. Bojo. A lot of people call me that because they can't say my last name. And I forgot to change this, but as of last Thursday, I'm a Kentucky Colonel. So I'm Dr. Colonel Lauren Wojcicki. I love this center. I feel like it's helped me grow a lot in my training. I'm a fellow, so I'm in my final year of training. I actually, my last day is in 56 days, not that anyone's counting, but after 26 years, I feel like the countdown's finally gotten to the point where I don't have to say I'm in training anymore. So it's very exciting. But anyway, so we're going to be talking a little bit about how we can be good caregivers, what we can expect from people with memory problems or dementia today. But first, I want to orient you to the brain. I feel like the brain is sometimes this abstract thing that we think of that's all encapsulating and all omnipotent, but it really can be broken down into some categories. So what we think about in brain organization, there's different parts that do different things. So our frontal lobe is really important in things like behavior and thinking. So think of when you have become inebriated and you've had a little bit too much to drink, you're disinhibited, you want to do whatever and you don't really care what anyone thinks about you and you just want to twirl. So the frontal lobe is a really important aspect of how you think and how you modify your behaviors to the world around you. When we talk about the parietal lobe, we're talking about things like language and how we feel things and how we can orient ourselves in space and time. So my parietal lobe is helping to tell me, okay, my water bottle is right here. And all of my other parts of my brain are coordinating that motor movement, but I can feel and I can orient myself to space through my parietal lobe. My temporal lobe is really important because this is where I'm going to learn things. This is where my hippocampus is. This is where I'm going to convert things from short-term to long-term memory. This is where I hear things, and this is also where I feel things. So I feel really excited to talk to you guys about that today. That's part of my amygdala. That's in the temporal lobe. But also we have our occipital lobe. So ironically, where we interpret what we see around us is actually in the back. You'd think it'd be in the front because it's close to our eyeballs, but actually your eyeballs have nerves that go all the way to the back of your brain, and it's actually the back of your brain that helps interpret the world around you. So my occipital lobe is how I can see you guys, and I can see color, and I can see you guys right way up and not seeing double. The other two really important things that are not necessarily in the cortex but are also really helpful for us to, think and exist in the world around us are with our cerebellum. That helps us maintain balance and coordination so that you're not walking all topsy-turvy, again, like you were inebriated, you're upright and you're able to walk normal. And our brainstem is actually the most primitive of all of our brain structures. It's where we moderate our breathing. It's where we moderate our sleep cycle. It's what keeps us being human and keeps us existing. So breathing, temperature control, that sort of thing. So just a brief overview to the brain itself. There's a lot of definitions on this slide. I include this slide because when we talk about about cognition and cognitive impairment and dementia, we want to understand what are the differences between those terminologies. And so for cognition, we're talking about mental processes of acquiring knowledge, understanding through thought, experience, basically how we interact with the world around us, how we interpret the world around us. When we talk about a mild cognitive impairment, we're talking about a time when we're having decreased cognition, but we're still able to interact with the world around us independently. So for example, we're having some memory problems, but we have compensated with our ability to use calendars, and we're able to make sure that we're putting on those calendars because we might forget otherwise. I know if I didn't have my calendar, I would not be here this morning. So that's an appropriate thing when we're having memory problems to compensate otherwise. So that might be suggestive of a mild cognitive impairment. We compare that with a dementia, where it's a cognitive decline in one or more domains. So for example, I'm having short-term memory problems. I'm having a language problem. I can't tell where my water bottle is, that sort of thing. When we have a problem with that and it's interacting or it's interfering with our ability to do things every day, that's when we start calling it a dementia. So let's go a little bit more in detail about what dementia is. Dementia, when someone says they have dementia, that's like a symptom, right? That's an umbrella term. People can have dementia, but it can be different identifiers. So we can have Alzheimer's dementia, we can have Lewy body dementia, we can have frontotemporal dementia, we can have vascular dementia. In addition to a whole bunch of less common ones that I have on the right that I'm not going to go over. But again, acknowledging that when we, for example, when we first get a referral in clinic and we see you for the first time, we are distinguishing whether you have normal cognition, it's like a spectrum. We're saying if you have normal cognition, normal aging, do you have maybe a mild cognitive impairment, or do you have maybe one of these dementias? And so our job would be to figure out, okay, if you're having this symptom, what one of these little raindrops is causing that symptom, if that makes sense. So I love this slide because it ultimately shows in years, and everyone is different. I don't have a crystal ball, so I can't tell, one person that they're going to be at this point in time with their cognition in this many years. But what we know is that cognitive function, when you do have a neurodegenerative process, will decline over time with the amount of years that you've lived. So for example, we know that normal aging, your cognitive function might go down a little bit. Maybe you're having trouble remembering names of one person you met 20 years ago. That's okay, that's normal aging. Sometimes you walk into a room and you're like, I forgot why I'm here. That's okay, that's normal aging. But there are certain things that are not normal aging. For example, I can't remember my grandkids' names. That's important. That's an important part that you should be remembering. So that's when we start getting into some concerning things. And I have a lot of questions about what normal aging would be versus abnormal aging in the next slide. But for all intents and purposes, normal aging, we know it slows a little bit over time, and over years, we're not as great as we once were. That's understandable. But with aging with disease, we already know up to 20 years in advance of you even having cognitive problems. With Alzheimer's specifically, you're already having buildup of amyloid plaques. So we can already tell 20 years before you start having memory problems that there is a problem. So when we watch you over time, we notice that the brain starts to compensate for changes, right? We start having a mild cognitive impairment. It's not impairing our daily functioning, but we're still noticing that there is definitely a difference than how we were thinking before. And then the end stage is dementia, where we are not able to function independently by ourselves anymore. So let's go into detail about Alzheimer's disease, because that's the one that's the most common, and it's the one that we treat most frequently here in the clinic. Alzheimer's is the most common neurodegenerative cause of dementia, and typically episodic memory is the first to go. Again, this is missing doctor's appointments. It's you're unable to make the change for when these things are happening. So remember when I said you're keeping your calendar to keep those doctor's appointments? And you start missing your doctor's appointments, that's a concern. And obviously we all have days off where one time is, it might happen that you forgot the appointment one day, but when it keeps happening, or if you feel like it's getting worse, that's when we're concerned. So if you're concerned, I'm concerned, we'll work with you for that. But ultimately, repeating yourself in conversation can be concerning. Forget having done something, forgetting a vacation that you just went on a couple weeks ago, like forgetting specifics of that can be concerning. And this can progress to more of an end stage where, when you're walking out in the neighborhood, you might get lost. if you're out driving, you can't find your way back home and you have to call someone. Those sorts of things are really concerning. Any progressive word finding difficulty, that can be concerning as well. And we know these things because we know that in Alzheimer's, remember when we were organizing ourselves to the different parts of the brain? We know that in Alzheimer's, the temporal lobes and the parietal lobes are the ones that are affected. So temporal lobes are why we forget, and parietal lobes are why we get lost. I don't know where I am in time and space. I don't know where my water bottle is. Well, that happens really specifically when people are driving because they're in places that they don't really know as frequently. And so getting lost is even easier. And so that's a concerning thing for us when that happens multiple times. On the right here, I have what Alzheimer's cells look like and healthy cell like neurons. So healthy ones are beautiful. They're fighting. They're clicking off all the time. They're doing good stuff. But these Alzheimer's cells have amyloid plaques and neurofibrillary tangles and tau deposits where it doesn't enable those neurons to fire quite as well, and it almost causes a barrier to those synapses trying to talk to each other. So it's almost like the brain stops being able to talk to each other, and the amyloid, that trash buildup, happens over time, and it makes it harder for us to think. So I said I would tell you what normal aging is and what abnormal aging is. So I'm not going to go through all of this because you'll have the slides, and I know a lot of you guys always have questions, but forgetting names of people you just met or forgetting something on your schedule, again, that can be normal, that's fine. But when you're forgetting more often and you can't recall newly learned information, that's a concern. Forgetting what you were going to say or why you came into a room, that's normal. But if you forget the steps to complete a common task, that can be really concerning. And these are more extreme. But just knowing that there are certain parts to normal aging, but there are some subtleties to where we can identify really early on if there's a concern. So if you're concerned, I'm concerned is basically the way that we work here at Sanders Brown. If you're concerned, I'm concerned. I'm gonna click OK so that I can see the top part of my screen. So when a lot of people wonder, okay, well, if I want to be evaluated for my memory, what is that gonna look like? How can I prepare myself? Well, if you've had any workup at all from anywhere else, please bring your MRIs, please bring your CDs. Like get your any neuroimaging, like any pictures of your brain that you've had, like CTs, MRIs, always bring those with you because that helps us get an insight into what your brain is doing. The brain is a muscle. And so rightfully so, if you're having any problems in your brain, sometimes we can see muscle loss in certain parts. So that can be really helpful for us to get you a diagnosis. So we might be able to say if you have mild cognitive impairment or dementia when you come in, but if we can get that picture, that might help us understand the etiology, meaning is it Alzheimer's, is it vascular dementia, is it Lewy body? That can really be helpful even ahead of the time. So what happens when you finally come here? Well, we get a memory consult from either your primary care doctor or another neurologist for specialty care. We get that referral. We get you the appointment. When you come into the appointment, we look at your vitals, we look at your medications, we talk to you about your memory problems, we do a neurologic exam, make sure your cranial nerves are working, that you don't have anything like a Parkinson's or a stroke that could have possibly been missed or might be contributed to your memory problems. Then we also do a cognitive evaluation, and I'll go into specifics about that in a little bit, what that can look like. But that's basically how your brain talks to my brain. So I'll ask your brain certain questions, and the way you answer tells me what's wrong, which is actually really cool that we can do that. Sometimes we can refer to somewhere called a neuropsych testing, this thing right here. That's like a 3 or 4 hour test. So that's an even longer test than what I'm giving bedside. Mine usually takes about 10 minutes. Theirs takes 3 hours. So they can really sometimes give us a good understanding of what's going on. I typically only refer people who come in and I see that they're normal, but they're having a problem. Like, okay, let's do this in-depth testing to make sure I'm not missing anything. So that's really important. After we've talked, we usually will get an MRI or a CT scan if you can't undergo an MRI, if you have a pacemaker defibrillator or a sacral stimulator or something like that, we'll get a CT scan. And again, that's going to help us understand what does your brain look like so that I can figure out what's wrong. We will also get labs. We always check your vitamins, your minerals. We make sure that there's nothing low there because that can absolutely cause a cognitive problem. If you're low in thiamine, if you're low in B12 or folate, those are all things that can contribute to memory problems. So we always test for those. And then when you come back, we review your labs, we review your imaging of your brain, and then we make a diagnosis. And if we can't make the diagnosis at that point, then we go a little bit further with other scans, which I'll go over in a little bit. but knowing what type of dementia we have is the best way for us to give you the best treatment. We don't like shotgunning treatments because at this point in time, we have enough information that we know what works for certain pathologies. So it's really important for us to figure out, okay, why are you having memory problems? I'm gonna admit this, Tina Sloan.
I just admitted her.
Okay.
Yeah.
Great. All right, so what barriers are there to diagnosis? So obviously not everyone has easy access to us. I am the first person to say I know that we have a backlog of people. It can be anywhere from 9 months to 18 months to see us. I know when I was even a resident at the VA, I had referred someone here. And by the time I finally came here as a fellow, I was actually able to take care of them and treat them. And I had referred them here a while ago. So we are very understanding to the point that we need more geriatric neurologists. We need more memory care doctors in the world. And that's what we're fighting for. And I understand that that is definitely something that we need. And it is, we are well aware. Please reach out to your legislatures. But ultimately, a lot of people can be unaware. That's why I described the normal aging versus abnormal aging. Some people don't know if it's a problem. Some people have been functioning so well their entire life, like they've been judges and doctors, that they don't actually know that there's something wrong, or they're trying to cover it up. They're like, oh, I'm just getting older. If it's that big of a deal and you're having to cover it up, please come see us. It's not worth it. Let us help you. We can get some medicines to help with your thinking. We can help you with resources moving forward, because again, these are mostly neurodegenerative diseases and we know they will progress. We want to get in there right at the beginning. We want to start treating it immediately and getting you all of the resources you need to have a happy, healthy, dignified life and aging with respect. So like we already talked about, evaluation is not easily attainable. Evaluation is also very time consuming. When you come into the clinic, expect to spend about 1 to 2 hours here, just by the time you've checked in, seen us, done the testing, been evaluated, talked to us about treatment plans. It can be a long time, and we understand that. So don't schedule your DMV appointment for right after after our evaluation, because you will be late or miss it. But yeah, we already talked about memory loss, cognitive decline. They're not always normal. Normal aging versus abnormal aging, they are different. So we need to identify that. And then there's a big belief still by clinicians and general public that Alzheimer's can't be treated. We know now that this is false. We can absolutely treat it. We have disease modifying agents now that can actually get at the underlying cause for Alzheimer's. So again, this is really important. We want to see you right when you're starting to have symptoms so that we have time to prevent the worsening as much as possible, so we can give you as much quality of life as we can. So we talked earlier about what is going to happen in the exam room. So our neurologic evaluation, we're going to test your muscles, we're going to test your sensation, your cranial nerves. This is not me, but she's getting tested. We'll get your reflexes. And on the cognitive testing, we can pick from a couple different things. If you've been tested for your memory in the past, each one of these are all very well validated tools. We have the short test, the Kochman, we've got the mini mental status exam, we've got the MOCA, we've also got the SLUMS, which is the St. Louis mental status exam. So we have several ways of evaluating your cognition. But these, again, are helping us to identify where in the brain is there a problem. We're neurolocalizing is what we always like to say. Where in the brain is the problem? And this test, your brain talks to my brain to tell me where is the problem. So what kind of labs do we draw? Like I said, we draw a lot of vitamins, we do thyroids, we look at your liver, we look at your kidneys, we're looking at all of your things. All your things we are looking at. And others we will add case by case. So for example, if you've had cancer in the past, we might add a serum paraneoplastic panel, because we know that sometimes when you have a cancer, that can release antibodies that actually will attack certain parts of the brain and make you have a cognitive impairment. So again, those are very rare and few and far between, but we will add that if we think it's necessary based off of your history. And then if we need to, we can also add CSF. People always are so surprised when I say this is what CSF looks like. CSF is cerebrospinal fluid, and it basically is the water, CSF, it's fluid, that covers your brain and bathes it and cleans it. So it's circulated all the time, and you make new every day and you recycle what you have. And ultimately, this can actually be tested for Alzheimer's. And this is what we're doing now. We will do, excuse me, I'm sorry, my allergies are acting up today. We will do a lumbar puncture, which if you've had an epidural, if you've had kids, it's the same thing, but instead of putting pain medicine in, we just take fluid out. So ultimately the same procedure, same all the things, but we can test that fluid for Alzheimer's. And in that moment, we can say, okay, do you have Alzheimer's or not? Sometimes it's inconclusive. We can send you for something called an amyloid PET, which I'll get into in a little bit. But again, there's multiple ways for us to test you for Alzheimer's now, which we didn't have a couple of years ago. This was all research-based, and we've been working on this for 30 years, or well, more than that. But it's really grabbed traction in the recent times.
What about the thyroid panel?
We test your thyroid.
What would that show? Like what?
Yeah, so if you have hypothyroidism, so for example, if you had your thyroid out and you're not taking thyroid medicine, that can really slow down your thinking. Thyroid is so important for like every system in your body. You can have things like hair loss, dry skin, certain things. Now, a lot of people have some hair loss and dry skin just at baseline, but that's why we do thyroid testing. I had someone who had a really really low thyroid ultimately. And I really think that is playing a prominent role in their thinking. And I don't want to do anything else right now because that is so intense. I definitely think that's what's going on for her cognition. But once I treat that, her memory might very well go back to normal. And she has dementia, like she is not able to do the things that she wants to do. So that's something that's really important for me to address, like, oh, if this is low, we should fix it, kind of thing. So I work with your primary care doctor to make sure that those things get addressed. So when we talk about common imaging modalities, obviously I've talked about the MRI, but I also talked about amyloid PETs. So amyloid PETs, when we talk about amyloid plaques building up in Alzheimer's, we can actually look at that on a PET scan. So what they do is they inject a radio tracer, which basically lights up when you have amyloid. So you can tell that here, you've got amyloid plaques, and they typically center in this temporal lobe, and then they'll grow over time, and they progress until they encapsulate the rest of the brain, and that is, a generalized end-stage Alzheimer's. So we can look at the amyloid PET and say, oh, there's amyloid deposition. We know you have Alzheimer's now. So this is an alternative to the lumbar puncture. Insurance has actually been really nice to us lately, and they've been letting us do the amyloid PETs because I absolutely would prefer an amyloid PET over a lumbar puncture. I don't want to stab anyone. It's not that bad. It's 20 minutes, it's in and out, and it's painless. But if I don't have to increase the risk for, an incision ultimately, then I would much rather do that. So I'm really happy that insurance has been more amenable to this. The VA is very amenable to it as well. So that's been really helpful. And then FDG PET, remember when we talked about the tracer? What happens is when you inject the tracer into your body, what happens is it goes to your brain. And the brain is a very metabolically active thing, right? It's a muscle. It takes up a lot of energy. So when we do an FDG PET, we can see places that don't take up that energy as much. That means more of like an atrophy. So for example, the red spots are really active. Like that's a good brain. Like that's a good brain. But do you see how some of these parts are, the blue's normal, those are ventricles, that's water. That's supposed to not be there. But do you see how these areas are like green? There's like no red at all in these temporal and parietal regions. This person has Alzheimer's because they're not having as much activity in the places that we know Alzheimer's starts. So the brain is a muscle. When that muscle wastes away, it's not taking up as much energy. So that's going to show lighter in color on our FDG PETs. So that's what we're using to help interpret, and that can help us localize where the problems are. I love this slide. It's very overwhelming, so we're not going to spend too much time on it. But this is just, again, telling you guys that up to 20 years before you even start having cognitive impairment, so this is time on the bottom and severity, like how severe your cognitive dysfunction is, we can detect up to 20 years in advance that you have A-beta 42, which is basically that amyloid that we were talking about. So it's this purple line. We can actually detect over here, even before you started having cognitive impairment, we can actually detect if you have Alzheimer's. We'll go into detail why I'm not going to get an LP on you if you have normal cognition. Like we're not going to test you for that if you have normal cognition because you don't have memory problems. We're not there yet with our clinical trials, but we will be very, very soon. We are already enrolling in clinical trials to address that question. But ultimately, you're going to be able to see that amyloid PET, the CSF. We're going to be able to look at that when you're having cognitive problems early on, and we can watch it because we know it will increase over time. This is a lovely slide. That's one of my favorites. Remember that cognitive test that we talked about, the mini mental status exam, how your brain talks to my brain? Well, we can correlate that with functionality, which is really helpful for our clinical trials when we're like, okay, how do we all speak the same language, right? How do you tell me about a person who has dementia from your aspect? How do you talk to me? Like, how do we compare results? And it's really important for you guys because this is what to expect when you're not expecting dementia. So for example, mild cognitive impairment is, so anything over 25 we consider normal. Now that's not always the case, but for the purposes of this talk, anything over 25 out of 30 is normal. When we get to 25 to 20, meaning you maybe lost a couple points on, remembering 5 words that I told you to remember earlier, you might have some trouble keeping appointments, but maybe you're compensating well. Maybe you're making a calendar. Maybe using your phone is a little bit harder than it used to be, but you're still compensating. You're still able to travel alone. You can still cook meals. But at a certain point underneath, like below this 20, then you start getting into dementia because now you're misplacing things. You put your keys in the sink and you put your dress on backwards and you put your pants on backwards and you can't button, or you can't use the washer and dryer like you used to. It's a little confusing to use that. And then you start getting into a little bit more intensive and severe dementia symptoms, meaning it's harder to feed yourself. It's harder to shower. You might need reminders to shower. You might ultimately forget what places to bathe. So you need help because you can't remember, oh, I need to wash my hair and my body, that sort of thing. So ultimately we can see on cognitive testing, that's why we test you usually every 6 months, we'll have you follow up and we'll evaluate you each time to see how far we're going. And that can help us with prognosis and saying, okay, how much time do we probably have? What do we need to talk about moving forward for advanced directives, living wills, that sort of thing. So what do we have for treatment? Well, we have a bunch of medicines now for memory loss. These have been well validated in the literature. They're about 30, 40 years old now. They're older than that, but them being used in clinic is about 30 years. So at this point, we have 2 classes that are our main oral medicines. So we've got cholinesterase inhibitors, that's Aricept, that's Exelon. Ultimately, the generics are donepezil and rivastigmine. Those are basically little brain boosts. Those help with stimulating your brain just a little bit. And those are great for people with all memory problems that relate to Alzheimer's, vascular dementia, things like that. So those are typically the first ones that we start on. And the second one that we will do when we start to notice that MMSE score, when it gets below a certain point where we realize that your functionality is it's a little harder to function independently, we will add on this Namenda or memantine, and that's an NMDA receptor antagonist. And that basically helps us improve with our day-to-day function. So one helps boost our memory, but the other one's been proven to help with our everyday tasks. So we combine the 2 together and we have a good powerhouse to prevent the worsening over time. And I have a graph in a second that shows you, but first I want to show you what the donepezil, there was a trial that they did where they gave people placebo, so a sugar pill. And they also gave people this donepezil, the first medicine that we typically use when someone comes in with a memory problem or suspicious for a neurodegenerative condition. So we gave them donepezil and they actually had an improvement in how they thought. We use a cognitive screening, like we said, and we saw that they had improved. Now, when we stopped that, they went back to a point where it wasn't quite on the same trajectory as you would expect with abnormal aging. These were the donepezil people. They came back down to where it had been with a placebo. So all that effect was lost when we stopped the donepezil. But when we did an open label extension, when we added it back on, they had an improvement again. And then they again slowly got worse. So again, helping to prevent the progression. These are symptomatic problems that we're addressing. This is not disease modifying, but we're helping address the symptoms of your thinking so that you can function better in your daily life. Well, Lauren, you just said that you want, an NMDA receptor and that other pill that you were just talking about, the donepezil. We also have studies that show, so you have no medication over here, and this is over years of time and how your thinking is over here. So ultimately, if you have no medicine, you expect to decline at a rate like this over the course of time. However, if you have donepezil, this is just like what we were saying earlier. You slowly worsen. Like we're decreasing that rate of progression. But if you do both, meaning we do donepezil and the Namenda, the memantine, we slow it even more. So that's the whole point, is we're trying to slow down that aging process as much as possible, that pathological process. The other thing that a lot of people come into or get referred to us for is the new anti-amyloid medications. These are infusions, meaning you have to go to an infusion clinic in order to get them. We have Leqembi here. We are currently in the process of getting Kisunla. The problem with Kisunla is that it requires more neuroimaging than we might have to offer. So we're trying to work with our neuroradiologists and our techs, because it requires a lot of things. There's a lot of moving parts to add a whole other infusion medication to our formulary. So I'll talk mostly about Leqembi. So I have Kisunla on here for completeness sake, but we'll talk about Leqembi most because that's what we do here. We have a lot of people on it already. Both of these are not a cure. We are not at a cure yet. We are so close. We are getting there. I'm hoping in the next 10 years that we will have a cure and we will have a vaccine and it will be amazing. But ultimately right now we are slowing the progression of disease. It's about 30%. So what does that mean in general? Well, ultimately, like I said, we're trying to give you more quality of life. So if we take the average range of worsening over time is usually 4 to 8 years for Alzheimer's. We're ultimately trying to give you up to a year of quality life back. Now, I took care of my grandfather with Alzheimer's, and I would love to have had another year of quality life with him. And I absolutely would have done this drug. A lot of people ask me that, so I'm going to tell you already. If you had the option, would you do? Yes, I absolutely would have, because I love my grandfather. He worked for the FBI. He was super smart. He was a fingerprinting analysis expert, and he had so many cool stories, and I just wish I had another year of quality time with him. So that's usually when people ask me, would you do it? Yes, absolutely. There's a lot of, I don't want to say naysayers, because they have a right to be skeptical, because they don't see this every day. But there's a lot of people out there who are like, does it really work? Is it really effective? And I believe it is. I've seen it firsthand that people have slowed in their progression, and they're like, I don't see a difference. And I'm like, that's perfect. That's exactly what we want. Yes. And they're like, oh yeah, I guess you're right. Yeah. So, understanding expectations of this is not a cure, but when we can slow it down and you can go on your cruise with your family and not have to struggle, and, you have a good time. That's what we want here at Sanders Brown. We want quality of life, aging with respect and dignity. That's our number one goal. Anyway, I'll get off my soapbox, but Leqembi is every 2 weeks. So it's not nothing. It is a bit time intensive, and there is a workup period that you need to go through, and it's not for everyone. But Leqembi is, again, one of those infusion medications where you're on it for 18 months. You do it twice a month, right? Every 2 weeks. So twice a month. We get several MRIs at the beginning to make sure that you're safe. And then after 18 months, we're going to end up switching you to once monthly. Now, I'm really excited because I just went to a conference and they said August 31st is when they're going to submit for FDA approval for an injectable. So now we're going to get the ability to do Leqembi. After you've done your 18 months, you just go home and inject it every week. You don't have to come to the clinic anymore for infusion. So I'm really excited about that. It gives me goosebumps. I'm really, really excited about it. It's showing that clinical trials and involvement in all of this research, and the research that's still currently funded as of now. But it's so important. It's so important for how we can help people with their cognition and help them to live a graceful life. So
Is there a certain point where you need to start someone on?
So if someone comes in and they're having a cognitive problem and they say, I'm concerned, we start doing the workup for Alzheimer's, because this is only for Alzheimer's.
Mm-hmm.
If you have that lumbar puncture that shows you have Alzheimer's, or if we do that amyloid PET that shows you have Alzheimer's, if you don't have any contraindications to this, and I'll go into detail what that means, we will start you, or we will recommend you to start on Leqembi. Obviously, it's up to you.
Mm-hmm.
It's your life. We're gonna let you decide. But we are, Dr. Jekyll likes to say, we are waiters and waitresses giving you options. And you get to pick your entree, as it were, because different people have different ways that they would like to live their life.
Mm-hmm.
A lot of people say, I don't want to spend, like, I had a patient the other day. They said, I am 89 years old. Even if I have Alzheimer's, I am at the point where I don't want to live out the next, however much time I have left going to infusions constantly. And that's very valid, because they had a lot of other comorbidities. They had cancer, they had neuropathy, and they didn't necessarily want that to be what their life looked like. And that is totally fine. is absolutely fine. We are just gonna give you those recommendations and you guys can decide for yourself. We're not gonna tell you what to do. That's not what we're here for. We're not dictators.
Can I ask an off the wall question?
Of course.
When do you give up? Like,
So we never give up. I don't want you to think like that because we never give up on aging with dignity. There's always something that we can do, whether it's helping redirect, doing, caregiver workshops, having social connection, that sort of thing. Now, when we decide maybe to, I think I understand your question, retract that medication, maybe is that what I'm
well,
hearing
even
or?
like, I mean, I was kind of off the wall, but my father-in-law, we could never get him in to see anybody, so he was never really diagnosed. But we couldn't continue to live with him, so we put him in a care unit. And so I don't know, do we try and get him an appointment and bring him back and get him diagnosed and find out if these drugs can work? And try and bring him home again?
I think I
Or
understand.
just leave him where
I
he
understand,
is?
and I'll have more on this presentation that will answer some aspects of that question. I don't want, if I'm understanding correctly, do you feel like you gave up when you put him in a living facility?
Because-
Okay,
Because we had no option.
Absolutely,
We were
yeah.
getting called every morning. My husband, they were living by themselves and independent living. And my husband and I were right down the street, but we were getting called every morning by my mother-in-law. Hurry up, get over here, because he was either in her face, scaring her,
yeah.
or he was gone. And we
And that's
told her,
terrifying.
do not
Yeah.
chase him, and so we were frantically driving around trying to find him. And it was because we couldn't get him here. We tried everything. We couldn't get in anywhere. And it finally got to the point that we finally got an appointment in Louisville, but I mean, it was too late.
It's too late.
We
yeah.
just couldn't continue to do that.
I don't want you to think that you gave up putting him in an assisted living. I think that's really important. A lot of people think that it's and this is what patients have told me. They feel like they did this. They put a person in assisted living. It's their fault. It's not. It is the best thing for your loved one to have them in a safe facility where everyone is safe. Being a caregiver is the number one hardest job that no one realizes. It is the hardest job, and it's one you didn't sign up for. Let's be honest here. No one asked for this. It happens, and I'm so sorry you weren't able to get in to see us. Like we were talking about earlier, there's just not enough of us to go around. And we're trying our hardest to get people in like crazy, but sometimes it is too late for people to think, but there's always things that we can do. So I'm glad you're here today to hear about the resources that we have. We have our memory cafe, we have this caregiver workshop, we have clinical trials too. I always say it's never too late. We actually have a Libby trial where for patients with severe to end stage dementia, we actually are giving them either it's CBD oil. It's a component of medical marijuana. So there's actually never something too late that we can do for people. We can always try and make you more comfortable. We can always try and make your caregiver support more affable. It's always a process that we want to work with people to make sure that everyone is aging with dignity and respect. And that's our goal. So
Follow up on her question, if you can't get in any place, what do you do?
It's usually really excellent to discuss it with your primary care doctor. And usually if it's something that they can't handle or they think that you would be a good candidate for a medication, they'll refer here. We're actually working on an expedited consult service here to where when your primary care puts in the referral, I think they might be a candidate for Leqembi or something that they may not be able to do, then they get a fast track referral to us so that we can get people started on. We just started people on Leqembi last year. So it's very new. It's very, very new. So we're still working on that. We are actively going into the community and teaching people about what memory problems exist, the new evidence and research, so that they can help treat those that we can't get to yet. So we are actively working in the community to try and educate because we know we can't do it all by ourselves right now. So we're leaning on our colleagues in our primary care facilities. And we also understand that if you can get another appointment somewhere else, that is totally fine. We want you guys to get the best care regardless. If that means here, if that means it's sooner somewhere else, just getting to see someone, just having people to say eyes. And they can always call us and say, hey, you know, I've seen this person. I really think they could benefit from Leqembi. Sometimes we get calls and they say, you know, I think this person would be a great candidate, and we'll try and fit them in even more so because we know, okay, another doctor has seen them and they're concerned. So we really want to make sure that we have that. So getting in with your primary care can be a really helpful thing. Okay. So we're going to continue on for the sake of time because I want to leave room for questions. But like I was saying, these medicines are not for everyone. Like we were saying earlier, this whole point is to decrease the rate of worsening and progression as much as possible. Now, obviously, when you get to a certain point in your dementia, meaning moderate to severe, these are no longer really doing what we wanted them to do because we've gotten to that point. So if you're already at a moderate to severe dementia, this medicine isn't for you, this infusion. The whole point is to prevent worsening, and we're kind of already at that end point. So we don't want to increase risk and increase burden on care time with this medicine with that. The other concern is that when you get to a point where you have so much amyloid in your brain and so much tau, those are those trash products from Alzheimer's, when we take them out, the brain is very unstable at that point, meaning when we suck out all of your amyloid, that's really quick that we're sucking it out and your brain gets it. Think of it like an infrastructure. If you swipe away the legs, the brain can collapse. And so that can predispose to bleeding and swelling, and those can be really dangerous in certain populations. So we always make an extra careful effort to make sure that the people who are included on this medications are safe for this medication. Our whole point is not to harm. So we always want to improve. We do not recommend genetic testing for everyone. A lot of people come in and they say, I don't have memory problems, but I would like to be genetically tested. That's not what we do here. If that's what you're looking for, that needs to go to our genetics department. That's a different department because that's family planning, that sort of thing. When we talk about ApoE, it's an apolipoprotein E, which basically is a big word that just says it kind of helps determine our risk for not only Alzheimer's, but our risk for developing ARIA, which is an amyloid-related imaging abnormality, which is that swelling and bleeding side effect we talked about earlier. When we do ApoE genetic testing, we're looking for primarily whether you're going to have a side effect to the medication, that infusion that we give you. We do not give ApoE to people who are cognitively normal. That is not what the current guidelines state. Because even if you test positive for this genetic marker, that doesn't mean that you'll get Alzheimer's. We have tons of people who have a genetic abnormality, is what I'll say for now, that would increase their risk for Alzheimer's, but they never get it. So when someone comes in and they're normal, that requires a different discussion than if we're working people up for Alzheimer's and for Leqembi. So when you're in the process of getting worked up for Leqembi, we will get this genetic test on you to determine what your risk of a side effect from the medicine is. So that's why I bring it up here. But it's not necessarily recommended for people who are asymptomatic and don't actually have memory problems. If you'd like that, contact your primary care. They'll refer you to a geneticist because a lot of children want to have that discussion. A lot of people ask what the risk is with lecanemab. So when we were talking about the ApoE, a normal genetic phenotype, meaning you got one allele from your mom, one allele from your dad. Normal is E3, E3. That's a normal allele. That means you don't have any increased risk for Alzheimer's. You don't have any increased risk necessarily for ARIA. E4 is where we start to get a little bit more of that increased risk. So some people got one E4 from their mom and an E3 from their dad. And here we see that there are certain people who have an increased risk, slightly increased in hemorrhage, right? If you have this genetic marker that says you have an increased risk for ARIA. ARIA H specifically is the one we're most considerate about. If you have E4, I don't know if y'all can see, sorry, my head's in the way, but E4, this is double the risk. You have up to a 40% risk of hemorrhage if you take this medicine. Now that's compounded on the risk of if you already have subtle oozing from your blood vessels that we can see on the MRI, you know, that we got in the beginning to see what was going on. If we find little subtle spots of blood oozing, this might be a really dangerous medicine for you, and we would probably recommend against it. But acknowledging that we do get that genetic test for a reason, and it's for this reason. We want to keep you safe. We don't want to hurt you at all. And so if you get that genetic test and you're E4, E4, we're going to have a lot different of a discussion than if you were E3, E3, or E3, E4 with your genetic testing on whether this medication would be good for you. Also, this medication is not, we don't typically, we currently at this institution do not include people who are on anticoagulants. So Xarelto, warfarin, Apixaban, Rivaroxaban, all those things. If you're on an aspirin or a Plavix, that's fine. But blood thinners, we know that can increase your risk for mortality and morbidity. So we do not do that here. There are some institutions that do. We find that the risk outweighs the benefit in that situation based off of our clinical trials and what we saw. So for us personally, we feel more comfortable not doing it. So in the last few minutes, I'm going to talk about behavioral symptoms in dementia. These are kind of those end stage behaviors that we try to ameliorate. And we'll talk about those a little bit more. But I love this figure because it shows what we see. You know how we said that we see that amyloid deposition up to 20 years in advance? Up to 20 years in advance, you can have things like depression and anxiety. They're fairly frequent in our patients with neurodegenerative conditions. Now, just because you have anxiety and depression does not mean that you will develop a neurodegenerative condition. Correlation is not causation. However, we do tend to see that when we look retrospectively, we're like, okay, there was more anxiety and depression in the past, and that kind of got worse, and then it led up to them having cognitive complaints. I can't tell you exactly why that is yet. We're still looking at it, but just knowing that there is a correlation, and we know that there's neuropsychiatric effects and behaviors that we notice even leading up to those neurodegenerative identifications. So, and then at a certain point after your diagnosis, you have the wandering, you have some agitation, aggression, hallucinations, being socially unacceptable, sexually inappropriate delusions. Those are all things that can come after we've made that diagnosis for the most part. But acknowledging that these are normal. These are normal things, and it's not the patient's fault. It is not their fault that they're doing this. They're not doing it on purpose. This is how their brain is functioning. And so it's really important. I know especially when they're being really agitated and you're just trying to help, it can be really overwhelming, but redirecting and trying to calm and realizing that it's not them, it's not their fault that this is happening is really important to fall back on.
We're going to talk about how caregivers sort of deal with some of those things you just had up there
I think that may be discussed today.
later today.
Yeah, because I think with Memory Cafe, I think, and other things as well.
We'll
Yeah.
talk about it a little bit.
Yeah, I think they'll go into detail about that too, because that's an excellent question. We ultimately want to identify if someone's having a behavior that we feel like is, you know, agitation or aggression. We want to understand what the trigger is. Is it overstimulation? Are they hungry? Are they thirsty? Sometimes in the later stages of dementia, they're not able to communicate as well as they used to. And so sometimes it's kind of trial and error of, okay, what's going on? Are you hungry? Are you thirsty? Sometimes they can't tell you. Are they in pain? I can tell you I've got some creaks and cracks. And so if I wasn't able to tell you that I needed some Tylenol, then that would be a big concern. And I would certainly act out. So sometimes if you know someone has a hip problem, or you know they have a back problem and they may not be fully optimized on their pain medicines, maybe giving some Tylenol and seeing if that helps with identification. If you can identify a trigger and you know what happens when certain things happen, you can help to address it. So we have a list here. Can they see things? Are their eyes working okay? You know, if I can't see the world around me, I'm going to be frightened. So helping to understand, you know, can they still see things? Can they hear things okay? Do they maybe, are they maybe having some delusions? Maybe illusions is more like what I would say. Like if I can't see very well and it's low lit, I could think if there was a coat here, I could think that's a person. And if I have dementia, I might be paranoid that they're trying to harm my family. And maybe that's why I'm acting out. So understanding that there might be different perceptions on what the patient has than what you're having, and kind of putting yourself in their shoes and be like, okay, what might be going on? Making sure that we identify that. I believe that unmet needs are, I would say 80%. And I say unmet needs. It's not that caregivers are not meeting the needs. That's not what I'm saying at all. It's that there might be some underseated trigger that we haven't identified yet. And that's why it's so important to understand where we're coming from. I love redirection. It's so critical for caring for a dementia patient because sometimes, for example, sometimes they really want to leave the home. Like I had one patient who constantly wanted to go for walks in the neighborhood, but it wasn't safe because whenever he would leave, he wouldn't be able to come back, or he wanted to go home. Like the current house he had moved into 2 years prior was not his home. So he was like, I want to go home. I want to go home. And so he kept leaving to try and go home, but then he would get lost. So we figured out a way to restructure his day because it seemed like at the same time every day he was wanting to go for walks. So what we ended up doing was we would take structured walks. So we would walk around the block and we would redirect the conversation to talking about something that had happened long time ago. Long-term memory is still there in our Alzheimer's patients. And so reminding them of something else, because they won't necessarily remember the conversation, but they'll remember how you made them feel, because that emotion is still there. They will still remember your emotion. So if you can talk about, remind me of the day you got married, or remind me of the day you had me, or, remind me of your job. Remember when you were an FBI expert and you were doing fingerprints? Tell me about that. And then they talk about that. They get into a different tangent. So you've redirected them, and then that trigger is now helped. So understanding and meeting people where they are is really important. Behavioral interventions, I have this here. I'm not going to go too much into it because I want to leave time for questions, but supporting the caregivers and communication through body language is always like my number one thing. If people see you acting abrasive, then they will subconsciously, it's social learning theory, you learn by your environment. So if you feel agitated, they will also feel agitated. And so maybe it is best for everyone to walk away. We are geared to have emotional feelings. That is important for us as humans. But it's important to acknowledge that sometimes we do need to walk away, and that is okay. You're not giving up on them. You are addressing your needs as well as theirs. And so walking away is okay. Obviously, keeping everyone safe with walking away, but treating the dementia first is also really important. Usually when moods become a little bit erratic, we tend to focus on treating the memory first, and typically some of those behaviors will go away. So when we put on donepezil or Namenda, those behaviors will actually go away when we've treated their memory problems. So that's usually a good thing as well. When behaviors start to get more erratic, you were mentioning earlier, when people are threatening to hit and kick and bite and harm, that's when we need to have another discussion. So ultimately, up until the point where someone is not actively psychotic, meaning they're having hallucinations or delusions, and up until the point where they're having harm to themselves or others, we are trying to redirect, we're trying to identify triggers, other things. But when it gets to a point where safety is involved, we need to have a discussion about an antipsychotic. The reason I make such a big stink about this is because when we start an antipsychotic, and there's other medications too that we use, like SSRIs, like Lexapro and Paxil and all of those things, we use those too. But when it gets to a point of physical harm, we use an antipsychotic, but antipsychotics in and of themselves do carry a risk with them. It does increase the risk of morbidity and mortality. It's not tremendously high, but the risk is there. And it's important for us to discuss whether that is helpful to you guys or not, because does the benefit outweigh the risk? I have had so many people who say, the risk, it was negligible compared to the benefit that they had after starting this medication, because their quality of life improved. The patients, they were able to enjoy life again. They weren't as angry all the time. And so then that's a discussion between you and your clinician on whether you want to start that or not. But if it gets to be a point of safety, always call 911 if you need to. It is okay. It is encouraged if you feel unsafe to call 911, and that can be addressed as well. These are common misconceptions that I wanted to address because I've gotten questions at the caregiver workshop about these in the past, and we wanted to make sure that they were noticed. But we can now diagnose Alzheimer's. I hope you guys have learned that today. We can diagnose Alzheimer's now. Your loved one actually can still make decisions after diagnosis of dementia. That's case by case as well. Sometimes people do or do not have capacity to make decisions. That's what will help you decide in in the visit. We do now know that there are treatments for Alzheimer's and dementia. We discussed that just because you might have a family member with dementia or because you might have that genetic test that predisposes you, that doesn't automatically mean you will get Alzheimer's. It just increases your risk. I've also heard Alzheimer's is diabetes type 3. That is a theory. And that is what we're kind of looking at in our clinical trials now. We're determining how insulin resistance and glucose, how they moderate Alzheimer's and how we can best treat people moving forward. Because we know diabetes and sugar issues, metabolic resistance, that in and of itself can cause a dementia. But now we're looking at how it interacts with Alzheimer's specifically. So I have to leave in 2 minutes, but I wanted to make sure, I know we answered a couple questions during it. But did anyone have any questions?
I have one question, well, two actually, but the first one is, what did you say it was called when you go in and you kind of suck everything out of the brain? Was that because, or,
Oh, that's Leqembi.
oh, that's the
Medication. Yep,
Okay.
it'll go in and take out all the amyloid and you pee it out.
Okay, and then my other question was, so if someone is on blood thinners, did you say that they don't need to take the medication?
No,
Or
it's
they
not-
Cannot take the medication?
Should not.
Should not?
Yes, because it increases their risk of bleeding. Because remember we were saying on that graph, the bleeding is the main concern. Bleeding
So all
can
of
be
that
really
is
dangerous.
medication related, but they can possibly do something else.
Yes, so
Okay.
yes,
And that's what about the Leqembi.
Mhm.
Okay, thank you.
you can have it just with Alzheimer's in general, but we know it's at an increased risk when you're on this medication. So that's why we address it, because you can have amyloid in your brain. You can also have amyloid in your blood vessels. And so that oozing I was talking about, that's amyloid angiopathy. Amyloid being from Alzheimer's, angio meaning blood vessel, and pathy meaning disease of. So amyloid angiopathy is the disease of the blood vessels. And we know that if you have amyloid in your brain, you probably have amyloid in your blood vessels. And so having that increased risk, we'll see that on your MRI, that oozing I talked about. We can see that on your MRI. And if you have more than 4 of those oozes, it's not safe.
Okay.
Yep, so great question, absolutely. Any other questions? Okay, well, I'm gonna go run to a meeting. Thank you guys so much for being here. It's
Thank
really,
you.
really great that you guys are here
Thank you.
and advocating for yourselves and your loved ones. Really, really
Any
good.
questions
you.
in the chat? No.
I realized when I started, I forgot to introduce myself. I'm Sarah, I'm one of the social workers here, and today we have Kelly, who is the other social worker here, to give a presentation about safety and some other caregiving tips and tricks, so I pass it to you.
Thank you. Hi, everyone. My name is Kelly Parsons. I apologize. I usually have a computer with like a notes view so I can like read it very clearly. So there might be a little disjointedness in conversation. But I think we'll get through it okay. All right, so my conversation is going to be about safety and dementia. And let's see, so Dr. Brajowski really did a great job going through the definitions of things. So I won't spend a long time on it. But the cognition is a complex group of mental processes that include memory, attention, language, and decision-making. And so when we're talking about Alzheimer's disease and we're talking about the testing and what the scores are and things like that, we are looking at their overall cognition and their overall functioning. And as she said, Alzheimer's disease is a medical condition that dementia is a medical condition that describes a group of symptoms to include memory loss, confusion, problem with speech, paranoia, changes in mood and behavior, and lack of initiative. So if you're seeing these things from your loved ones, this is all a normal part of the disease. It's not because they want to, it really is the disease in their brain creating these conditions that are coming up and that you're seeing in real time. All right, and she did talk about the cognitive testing, so I'm not really going to go into it, but I just want to say that these tests, the reason they perform them, it's not to make them angry, it's not to make them look like they're not intelligent. It really is to gauge where they are within this disease and what we can do kind of to implement safety barriers to keep people safe, communication, different styles of communication so that people can have a decision in what they're doing, things like that. So there we go. Okay, but I did want to kind of talk about the MMSE because that's the most common testing. And in regards to safety, the MMSE can give us a baseline of cognitive function, and it can follow the cognitive decline in a clinical manner. It can also assess specific cognitive domains of memory and thinking. And those cognitive domains that we're looking at in regards to safety is orientation. So they're assessing the awareness of time, place, and person. The registration and recall, so tests immediate and delayed memory functions. So they're looking at short-term memory, things like that. Visual spatial ability. So like if you're driving in a car and you're having trouble, then that might be an indicator that we need to talk about driving safety. And she also talked about this, so I won't get into that. But this is really kind of our bread and butter of my conversation with you all today. So Alzheimer's causes a number of changes in the brain and body that may affect safety. Depending on the stage of the disease, this can include judgment, so forgetting how to use household appliances, sense of time and place, getting lost on one's own street, the physical ability, so having trouble with balance and frequent falls, senses, this can experience change in vision, hearing, or sensitivity to temperature or depth perception, and behavior. And I think this is what you might have been hitting on, but becoming easily confused, suspicious, or fearful are all common in Alzheimer's disease. So it's important to be aware of safety needs, as this will help prevent injuries and assist in the person with dementia to feel more relaxed and less overwhelmed in their own space. So looking at judgment and decision making. In Alzheimer's disease, the neurons lose connections as amyloid plaques and tau tangles accumulate. This will affect judgment and decision making. So some of these things that you can do to kind of help keep people safe. First and foremost, set the hot water heater at 120 degrees. People can lose the sense of touch, so they don't know that it's scalding hot, but it really is. You can also put red tape or fingernail polish on the hot water faucet to ensure they don't get confused between which one is hot and which one is cold. You also want to monitor oven use and stove use. I'll talk about that in the next slide, how to do that. But if it's necessary, unplug appliances, remove the stove knobs, or disable the garbage disposal. Just some things to think about. This is really, really important, and we'll talk about scams in just a minute, but monitor finances. If you've got a power of attorney, if your loved one has entrusted you with a power of attorney, that's the most position of power you really can get. I mean, they are saying that you can make decisions if they're not able to make decisions. So when you're coming up to these hard decisions and you have to really put in line, we always talk about the line to really go against their wishes and what needs to do. That line is safety. So if it's not safe, if they continue to elope, if they continue to be violent, if different things like that, if you try to remember when you were sitting at that table signing that paperwork, or when you were at that kitchen table and your loved one was handing you that paperwork, they were handing that because they entrusted you in the decisions they understood that at one point or another they would no longer be able to make. And it could be, it could be they didn't have Alzheimer's disease. It could be maybe they were going to get that just for safety purposes, as far as if you got in an accident or if you had to travel somewhere far away to take care of somebody, things like that. So monitor finances and limit the amount of cash your loved one has access to. Gain access to their checking, savings, and other bank accounts, and provide them. We also, as we're talking about this, really want to keep in mind autonomy and self-determination of the person with the disease. So giving them a prepaid debit card so they can go to McDonald's and they can enjoy their morning at McDonald's with the breakfast club that they have and pay for themselves and not have to worry about that. That's something that you can give to them that restores their own autonomy. Keep firearms locked and ammunition locked in separate places, or better yet, remove them if you're able to. It's harder to take somebody's guns away than take somebody's driver's license away. So I understand that can be a really hard conversation. lock up or put above on top of the refrigerator sharp objects, or maybe put the knives in a drawer and have one of those child locks on the drawer. Secure power tools, lawnmowers, and outdoor grills. Also watch limited access to hot tubs or pools, make sure the cover's on, things like that. We also want to store medication in a locked cabinet if they're no longer able to take medications on their own. Remove expired prescriptions. Most pharmacies will have, you can provide them with the expired prescriptions and they'll take care of it. They'll just destroy it for you. Keep an updated list of medication on hand and ensure each doctor has a current copy. And this is really important because my mom's cardiologist doesn't talk to her endocrinologist because one's at Lexington Clinic and one's at UK, and maybe another one is at Baptist. The primary care is at Baptist. Now, some of the electronic medical records can talk to each other, but it's really important that everybody kind of knows. And if you're curious of how to get that, go to the pharmacist. The pharmacist has all of your loved one's drugs and what they're taking and the amount that they're taking, and they'll print you out that list. Also, you want to think about reducing or discontinuing alcohol intake or supervised drinking. Ask the doctor how much alcohol is appropriate. Now, we don't want to just go cold turkey if somebody is a heavy drinker, but a lot of times what we'll do is, because people forget, they forget that they've had their 2 beers a night, and so they end up having the 8 beers that are in the fridge. And then they get really mad because they say, but I haven't had it. So there's a great option in non-alcoholic beers. We had a lady that avoided going into a facility because they switched her from Miller Lite to O'Doul's. We have, there's non-alcoholic wines. Sometimes we have caregivers pouring the non-alcoholic wine into the bottle that looks like alcohol. Just some of those things that you can do. And again, we're not trying to trick anybody. We're not trying to fool anybody. We're just trying to keep people safe and comfortable in their environment. All right. So the next thing is to kind of think about, I'll talk about elopement in just a minute. But think about trying to get people to not operate machinery if they're not able to appropriately. Warning signs really help. This is a wallpaper that you can put over a door to look like a bookshelf. These are really nice. I've seen them in memory care facilities, and really from a distance, it does look like a bookshelf.
And so they wouldn't try to go into it.
Right, well, it would lessen their chances, because if you're trying to elope and there's a door, you're gonna run to that door. But if you're trying to elope and from far away or from, 30 yards back, it's a bookshelf, then they're not gonna try to go up and go out.
That's what my father-in-law, where he is at, all the doors have stuff.
Oh,
Yeah.
that's really cool.
So we have to talk about safety and scams because it is absolutely rampant. Now I've got some information about different things you can do. I don't think are the slides sent via email after this? Perfect. So you'll get these slides. But these are just some things that you can do to prevent or try to prevent some scams. Having conversations often, monitoring financial accounts, speak with banking institutions to see if they're able to put safeguards or monitors. I know my parents, you can do something with all the credit agencies where you just turn off your credit so you can't get access, so you can't get new credit cards. But monitor emails and encourage them to never let someone have access over the phone to their computer. Scammers pretend to be from organizations they're familiar with. They can change the call coming through to look like it's a legitimate entity. And this is kind of what we say, especially people who might be at that moderate stage of Alzheimer's disease. Scammers are going to tell you you've won a prize or there's a big problem. There's an urgency. They don't want you to hang up the phone. They're going to try to get you to stay on the phone as long as possible and keep telling you how urgent it is. And then they're going to require payment in a specific way, like gift cards or a MoneyGram. Doorbells, Ring doorbell or cameras in the home are really great, especially if a loved one is really trying to stay in the home and you're getting some added protection in to keep them safe in that home. You can have, this might scare me, but there are cameras you can install in the home now where you can talk through them. So like if your alarm's going off that they didn't take their medication, you can just kind of push the button and say, hey, mom, take your medication. Which I think is, technology is,
Yeah.
I get confused a lot of times about it, but it's pretty amazing stuff. So driving safety and wandering and getting lost, and these are two really big ones. So again, Alzheimer's disease is a progressive neurodegenerative disease. Due to this progression, most persons diagnosed will become unfamiliar with their surroundings to some degree. When noticing a decline in concentration or orientation, it's important to observe your loved one's abilities and modify routine as needed. So if you're thinking maybe their driving is starting to impact their driving, take a ride with them, see how they're doing. Are they driving too fast? Are they driving too slow? Is there a lot of road rage happening? That's another big sign. And then if you do not feel comfortable with your grandchild driving with your spouse or loved one, then it really is time to have a conversation. And this is where Sarah and I and Regina and Meredith and all of us professionals come in. We can help you have those conversations. Your physician can help you have those conversations. Dr. Jika will often write on a prescription pad, no driving until the next assessment after he switched up some medications, and then put it on the fridge. We try to keep the blame on us as much as possible because we don't live in that house and we understand how frustrating and just difficult it can be. So a few other things in regards to decline in concentration and orientation, a large calendar or whiteboard in the kitchen can help. This can be written with the day's event. So you've got a doctor's appointment or Sarah's bringing lunch over at noon, things like that. Also kind of prepping them for what's coming. Hey, in about 20 minutes, we're going to get ready to get out the door. Hey, in about 5 minutes, we're going to get ready to get out the door, because it can be difficult because we know when we need to get out the door, we got to grab our keys, we got to get our phone, we got to get our shoes on. All of those things are all automatic for us. But somebody with a neurodegenerative disease, that processing time is so much slower. And just the idea of thinking about what you need for the trip just really isn't there, because Alzheimer's disease really is focused in the now. Using labels or pictures on cabinets to help your loved one know where the dishes go. So again, they can keep that autonomy. They can keep being of service in the house and contributing to the household. Using voice activated timers like an Echo or an Alexa for medication reminders can be very helpful. And again, reaching out to professionals and community. Lexington and the surrounding cities have a really great dementia professional community. And so there's lots of different avenues to seek help. So action items for safety, thinking about activities to combat wandering or that I want to go home, or just being dysregulated in general. Utilizing community organizations for dementia-friendly events like Memory Cafe. We also have early stage support groups for caregivers. Become regulars at a favorite restaurant. In Lexington, we also have dementia-friendly certification where restaurants will take training to help with that. But getting having, servers understand what your situation is. We've got these cards provided. Just showing this card to somebody really can change the whole room. Especially if somebody might be a little bit demanding because they're a little bit confused. Let's see. Check with your local senior center for low impact exercise classes. Certainly ensure that the physician approves the level of activity that suits you best. The YMCA also has a silver sneaker program where your membership is paid through insurance programs. You also want to make sure your loved one isn't hungry or needs to go to the bathroom or isn't thirsty. One of the things we forget the most in this disease is to drink water. And with this, as soon as it gets hot, we get a lot of phone calls for behavioral issues, because if you have Alzheimer's disease and you get a UTI, I don't know if anybody's experienced that before, but it very much changes your behavior. You can become very aggressive. It's really, really difficult. So just keep in mind those things that might be happening to your loved one that they might not be able to tell you about. All right, and thinking about safety, if somebody is an eloper or a wanderer, there's a lot of different things. I'm sorry, I forgot to grab it. I'm gonna go grab this. There's a lot of different things you can do around the home. Thank you. One of those is, it can be simple, and low cost. It can cost a lot of money, but you can get these. I think I got this at Dollar General, Meijer, Walmart, but it's just a magnetic door alarm. So if you hear your loved one's bedroom door opening and it goes off in the middle of the night, that might be, or put it on your door to the front door, or get an alarm system. Those things might help. Also, if you put your lock above, so normally door locks are right here, but if you maybe put a chain lock right here, your loved one with dementia doesn't know how to get to it, but you know how to get to it, God forbid, if there's any reason that you need to exit very, very quickly. Of course, in regards to door locks, due to potential hazards that could cause an emergency, if an emergency exit is needed, door covers, door locks or door knobs, those covers that you put on the door that spin should only be used when a caregiver is present and able to assist. Placing stop, do not enter, or closed signs on doors is also a really good way, like on the front door. And then another thing, I was talking about perception, depth perception. People with Alzheimer's disease, if they see a black rug, they think it's a big hole. So sometimes just putting a black rug by the entry door you'll be able to divert them from wanting to elope. Excuse me. All right. So driving concerns. This is such a hard conversation, especially because we are such an automobile society, but trouble locating familiar places, trouble following directions to find new places, failing to observe traffic signals, driving too slow or poor decisions, becoming angry or confused, poor lane control. If you see all of a sudden their fender is just, dented all to heck, you really want to think about maybe you should stop driving. I know we talked about it a little bit, but approaching the conversation is really having a conversation with your loved one. Again, regardless of the disease, they still have their own autonomy. But having a conversation about safety, having a conversation with the doctor, and plan for alternatives in driving. So how do I stop the driving, right? Well, I can have this piece of paper on the refrigerator, but they're not, that doctor's not there when they're yelling at me. So a few things: remove the keys or give them different keys, or file the keys down. We had a gentleman got his keys taken away and then had huge behavior issues. And it wasn't because of the driving, it was because he owned a grocery store and he always had his keys. Having his keys was his lifeline. So they just put new keys on and gave him that old keychain that he's had for the past 30 years, and he felt more secure. So there's just different things like that you can do. Taking the battery out of the car and just putting it in the garage and saying, I don't know why it's not working, and we've had people that'll tow it to the mechanic, call the mechanic beforehand and say, hey, I'm really trying to alleviate this. Yeah.
Or coerce their husband to put it back in.
Yes. Yeah. Oh, yeah. And then, so Cardinal Hill and Norton and Louisville do driving evaluations. They used to give you a certificate saying like they've passed the driving evaluation. Out of probably, I want to say at least the 40 to 50 people that have been to a driving evaluation in my time here, one has passed. So that's another way to get somebody else to say you can't drive. And then.
So it's not the loved one saying it, it's like a
Right,
professional.
and they
Yeah.
take you out on the,
Mhm, yeah,
We
okay.
had the doctor order a driving evaluation and then he didn't pass. the
Oh,
driving
one
Oh, that's good.
evaluation.
Yes, then you're not the bad
I'll get you
guy.
that information.
Mhm.
Well, it's
But-
hard for me because I'm blind, so I
Yeah.
can't see.
Yeah.
So when I tell him he's close to something, it's like, you're off.
Yeah.
It's a double whammy at our household, okay?
Yeah. So another thing that we cancel families on, now, we have a research guide and nobody's allowed to research records. Even the confidentiality would have to be broken by the US Supreme Court in regards to research. However, we also have UK healthcare. And if you have been diagnosed, and of course you want to get diagnosed because Dr. Brodowski talked about all those amazing medications, but if you want to if it's in your healthcare record and you get in an accident, regardless of whose fault it was, if the insurance company sees that diagnosis in that medical record and that person you hit is litigious, they are gonna take everything you have. We also have had, we've had patients on the wrong way on 75. I mean, it happens. It really does, regardless of how much counseling, regardless of all of those things. So I understand how, though it's not a lived experience of mine, I understand how difficult it can be and frustrating it can be when you're trying to keep your loved one safe. Especially, and I can't remember what it's called, but there's it's not Bluegrass syndrome, and I don't know if Dr. Brodowski talked about it, but literally sometimes with this disease, they don't know that they have a memory or thinking problem. I do a scale where the first question I ask people is, do you think you have a memory or thinking problem? And I'd say it's a 50-50 of yes and no. And these are people with a diagnosis that truly have one. And it's not that they're trying to get one over on you, or it's not that they're in denial, it's that there's the delusion that they really don't have a problem. There are quite a few driving alternatives, and that'll be in the note section. So when you get the PowerPoint slide, there should be a note section that comes down. But the American Red Cross, and the Bluegrass Ultra Transit Service, Federated Transportation, and then in Fayette County and Jessamine County, the IT and Bluegrass as well. And I think some people do Uber, but that's a whole nother thing. There's also lots of private drivers that have popped up recently that I've noticed, kind of seeing advertisements for. My fancy animation, sorry. All right, so physical abilities, and we talked about this as well, so I won't get too into it, but just thinking about and looking at fall risks. So in the stairwell, if you have handrails on both sides of the stairwell, that's super helpful. Make sure the lights are on. So many falls come from bad lighting. So if you've got those plug-in night lights that are motion detective, that's also super helpful. Carpets are firmly attached, pull up the rugs. If you are over, if you're over the age of 65 and you break a hip, you have a 50% mortality rate. And that's just the way it is, because hospitalizations can really mess up people who are older. And then if you get a hospital acquired infection and your body's already fighting this disease as hard as it can, it's harder to fight other things that come along. So just inspect things that a person can easily trip on, like clutter, stacks of newspaper, telephone cords, electric cords, things like that. And then also make sure your loved one's shoes are fitting properly. Our feet shrink when we grow or when we age. Also, if you've got a little bit of balance issues, I know my mother-in-law has MS, she must have at least 25 different tennis shoes because she's trying to figure out which one stays on her feet the best, because sometimes you can walk out of your shoes, which one kind of supports her the best.
Your feet shrink.
Mm-hmm.
Huh.
Yeah, I don't know if this is true, but our nose continues to grow.
Yeah,
every year. Yeah.
Nose and ears and our feet shrink.
And we shrink when we're older, osteoporosis,
Yeah.
like it just, a lot of times too, we lose more weight than we had, in our midlife. So, yeah. Also, if you have a home health referral, they're great occupational therapists. While it can't be the first reason for a home health referral, but if you need like PT or nursing medication, education, you can also ask for an occupational therapist to do a home safety assessment. So they can really get in there and say, like, this would be a good place for a grab bar. This would be really good if you moved us over. Just some tips and tricks that you can have. So again, with that hip thing, I just want to make you all aware, there's a lot of different things you could do in the bathroom. A shower chair, having a sprayer like you see over. Whoa, shoot, sorry guys. There we go. Having this right here so that it's a little bit more easy. Again, a well-placed well-placed grab bar will save a hip. I do believe that. And then, and we'll talk about depth perception, but you can get these again. Meyer, I think, is where I found this. It goes on the bathtub, but if you're looking, or make sure they're not slipping. So get some stuff on the bathtub if you have it, or in the stand-up shower if you don't.
And how about when you order the shower chair, you ordered 3 shower chairs, and you keep coming in there out and they got clothes all over them. Right? The shower chair, let me get a smaller one. Do you want a bigger one? And then you keep coming in there, just clothes.
Do they take it out? Oh,
They take it out.
Okay.
Yeah, and it's
Yeah.
both my mom and dad. They're doing this at the same time.
Oh, wow.
It's hard, but yeah, they will not put the shower chair in the shower. Or we put it in the shower and they keep taking it.
Right. Yeah.
For your safety, please.
Yeah, you know, and also maybe a sign that says, keep the chair in the shower and sit down. They might not know that they can sit down on it. So maybe kind of go in and say like, hey, sit down on this. And I'm gonna turn on the water and let it run, and then you sit down on it. If you don't, a handheld is really, do you have, shoot, let me go back.
Like the.
Yeah, do you have this little
No.
guy? So if you get this guy, oh,
They have one
whoa,
of the-
sorry.
They have the handheld, but not the bar. They've
Okay,
got the handheld shower.
but if you just if you put the shower in there and just show them how to use it,
I'll try
that might be, they're just like, I don't need that, I can just do this, but
We've
also.
done it with them, so.
Oh,
they
okay, so they do
but
know.
I will try that
You
again.
get little signs that say like stop or sit or, you know, things like that. I mean,
The hardware store, you
Okay.
know, at Lowe's, you know about hardware store, you can print them out yourself,
Okay.
for printing, what is it?
just laminate them or something.
Yeah.
Mhm.
I can't think of the print place. I wanna say Lynn's Printing, but that's not it.
To be.
Um, But yeah, and just a sign, don't take this out, maybe laminate a sign that says, don't take this out of the bathtub.
I know that's not gonna work.
Okay.
Not not, but I will try. Oh, God.
Yeah.
Oh, move that sign so quick.
I didn't see this.
But I will try to just sitting them down and try, and tell them, this is what you need.
Yeah,
I'll try that.
Picture of somebody using it, I mean, in their bathing suit or something, but like, instead of having to interpret a word, sure, of somebody doing what you want them to do.
Maybe.
They're not rule followers.
They want their independent, they don't want to.
Right.
Yeah,
Yeah.
that's what we're going to do.
and what I'll say too is we are trying to implement this to keep you in your house as long as possible.
Now
And
that-
if something
that's-
happens,
The first one falls.
right, and
Yeah.
if something happens and you fall in the shower and you're not able to mobility wise to get around the house, then it'll be a different environment. So the senses, sight, there might not be anything physically wrong with their eyes. However, the brain's ability to interpret images may decrease. This can cause confusion and disorientation. Smell, so look for spoiled foods in the refrigerator because they just don't smell what we smell. Taste, losing effect. I don't know if your loved ones really crave sugar or really crave salt, but part of the sugar is it lights up our brain and we get a lot of energy of it, but also taste. People can't taste as well. Hearing, as in the case of the eyes, a person could have a perfect hearing test but not be able to process sounds. So if you notice kind of further on in the disease, when you all are in a conversation with a group, it's much harder for them to really understand what people are saying because it's hard to focus on that person that's talking because all of the sound kind of comes in together and they can't process what conversation is the main conversation. And then we talked about touch, so I really won't get into that. So depth perception. Now, see how the toilet kind of fades into the wall, but if you've got that orange wall, the toilet pops up. We had a caregiver that said, you know, my mom won't get into the shower. I can't get her into the shower. It was a white tub with a white wall with a white floor. And what it was is her loved one was scared because she didn't know where the tub began and the floor ended. So again, using these things for the sides of the tub just to break up that color. If it's a monotone, if everything is monotone, think about how that looks because sometimes it's hard to break that up. Let's see. So we're going to talk about behavioral and psychological symptoms of dementia and safety and how that can affect. How am I on time? I'm sorry.
It's 10:35.
Okay, all right, we'll wrap this up quick. So we talked about behaviors or maybe an expression of unmet psychological needs. Thirst, hunger, pain, distress, fear, feelings of abandonment, not knowing what happens next, right? We all know what's going to happen next after we leave here. People with Alzheimer's disease don't. They're very much in the moment. So kind of that prepping them for what's happening next, prepping them for how their day is going to go. Constipation is a really big one. Monitor their bowel movements because it can cause a lot of aggression. Recent falls. So wanting to go home. It's not that we had a person move they were living in Rhode Island and moved back to Ohio, their childhood home. They had kept the house even though they had not lived in Ohio. They kept the family home, moved back in, and the wife was still saying, I want to go home. And the husband was so confused and distraught about it. It's a place. So when you hear somebody saying, I want to go home, and Diane will talk about communication, but just assure them that they're safe and that they're loved. It really is a place. It's a feeling, not a place. So some behaviors, while frustrating to the caregiver, can be soothing to the person with memory and thinking, like the humming behaviors. If you have somebody that, sometimes that's really for our vagus nerve. It really is calming. Remember, due to this is a disease, it's hard to remember that with your loved one. They're not trying to get back at you. They're not trying to punish you. They have a disease of the brain. I won't go into more communication. Diane's going to do that. But unsafe behaviors, hallucinations. We say hallucinations are fine if they're not scared of them or if they don't think somebody's trying to harm them. There's a Lewy body disease, which is a form of dementia. People often hallucinate children and animals. And if the kids are up in the tree playing and your loved one is fine with that, we don't need to do anything about that because Dr. Brzezowski was talking about those black box antipsychotic medications. But they do interpret reality differently than you and I. And due to this disease process, trying to orient them to actual reality is impossible and will both frustrate you. So during a hallucination, a person sees, hears, smells, tastes, or feels that something is there that isn't there. Delusions are false beliefs that people think are real. We had a caregiver who had a delusion that their husband was having an affair, and this caused lots of confrontation with each other. The husband said, I'll write my odometer down before we go to bed. So they go outside, they write the odometer down. Morning, they wake up, they both go outside, they look, the odometer hasn't changed. The loved one says, you took your friend's car. I mean, very much they will make their delusion make sense for them. Paranoia is a type of the delusion in which a person may believe without a good reason that others are mean, lying, unfair, or out to get me. He may become suspicious, fearful, or jealous. I do want to caveat this with an asterisk. some paranoia is actually happening. My grandmother signed helped co-sign a car loan for my cousin. This was years and years ago. And my cousin wasn't paying for it and the bank was about to take the car. And my grandmother kept saying, who had Alzheimer's disease, they're trying to take my money, they're trying to take my money. And we all just kind of thought it was a delusion because nobody knew that she had signed for this cousin for this car loan. And then lo and behold, the bank really was trying to take her money. So if you hear some of the stuff in regards to financial stuff, look into it. It's a good idea. Made the funeral really awkward for us, but just, you know, it happens. So let's see. Turn off the TV if there's a violent or upsetting program on. Sometimes people with Alzheimer's disease thinks it's happening in the room. So if Gunsmoke is on, they think like Gunsmoke is actually in the living room. Let's see, make sure the person is safe and can't reach anything that could be used to hurt them. That's, you know, knives in the drawer is a really great thing. Changing the surrounding. There is nothing like going outside now that it's getting nice. Or if you're all in the living room and you're trying to get your loved one to take medication, and it is just an absolute fight. First, you just want to stop, pause, take a break, come back later. If it's the same thing, take them to the kitchen. You know, get them outside, go for a drive. Different things like that are so, so helpful. A person can become paranoid where they put something, they may believe something is taking her things. Just know that that's part of the disease. Help them find it, help them look for it, things like that. So these are using technology to keep you safe. That little guy is an automated pill dispenser. So it's only gonna open, this door is only gonna open for the morning pills that they need. It's not gonna have the whole day's pills. It's also gonna beep until they open the case. There are some that are really, really fancy, and they'll send you a text message that says the pill dispenser did not get open. So then you could follow up with a phone call. That's really nice. Automatic night light safety alert systems have come a long way from I've fallen and I can't get up. You can have little air tags. It can look like watches. It can look like necklaces, just different things like that. If you're in the moderate stage, you know, you try to log on to your email and you need to put a code in to go to there, to here. Smartphones have face recognition. Help set up your loved one with a face recognition so they can get into their phone a little bit faster if they're still able to use it. Also, group messaging app. If you've got a loved one that really just bolts for the door consistently, talk to your neighbors. Maybe all get into an app together. So if somebody sees your loved one out and about, they can shoot a quick message on the app. Oh goodness, Mr. Kaziz down there, down at, Dave's house again, just things like that. Find My Phone is really great for the iPhone. You can also have Life 360 if you have just a smartphone in general, and it's like an AirTag, and you can track where a person is going, which is really, really helpful.
They forget their phone, you don't.
Right.
What happened to them?
Right. Yeah, and they've got stuff now where you can put AirTags in shoes. So the technology has really come a long way. We had a lady that loved her evening tea, and it was not safe for her to use the stove. And instead of not allowing her to do it herself, right, because we want people to stay as independent as possible, they just got her an electric tea kettle, and then she was able to do it safely and on her own. And then I'm not going to talk about this, but this is just some information for you. These are the 4 most common types of dementia. This will be in the email. These are just some safety things that you can do in and around the house for fall risks. And then this is really fantastic. It's tips for managing agitation, aggression, and sundowning to try to keep a safe environment. And then, that was our next one. A little bit of firearm safety. So that's it for me. Any questions? I'm sorry, it's a little fast.
One of the slides on shadowing.
What
is that?
So shadowing is when the person that you love is just always kind of right here. They just don't want to leave you. And really it's a safety measure. Again, they don't know what's happening next, but they know you know, and they know you are keep them safe. And so it's that just taking deep breaths and speaking of deep breaths, let's see, Regina's gonna.
Right. So thank you all so much for being here. So I am actually going to talk a lot about some local resources and our agency. I'm Regina Goodman with the Bluegrass Area Agency on Aging and Independent Living. And I know that is a mouthful, but I'm going to talk about some of the things that we do to support our caregivers and some other things as well. But I've got lots of little goodies with me that I will talk about, and then at the end, you'll have the opportunity to take with you if you think that that would be. Okay. So you may hear me like I said, we're the Bluegrass Area Agency on Aging and Independent Living. We are housed at the Bluegrass Area Development District off of Alumni at 699 Perimeter Drive. And so we are kind of just one of the departments at the ad. We have aging, workforce, community development, those types of things. So you may hear me in the course of talking to me say some of these acronyms, and we are part of the Kentucky Department of Aging and Independent Living, which we call DAIL. And then you heard me say Bluegrass AD, that's Bluegrass Area Development District. And then there's no easy way to even shorten Bluegrass Area Agency on Aging and Independent Living. It's a mouthful, even if you say BGAAAIL. And so sometimes we try to call ourselves the AAA for short, but then people think we're the auto that's going to come down and fix your tire. And then our ADRC is our Aging and Disability Resource Center. You will hear me talk about that. And then Older Americans Act. That is where our funding comes from for a lot of our programs. So we'll do that a little bit. And so our mission is to promote and provide for the development of community-based systems of care, which include planning and access and delivery of services, coordination of activities and programs, and advocacy. We do not do direct care at our agency, but we are a resource for those programs. We cover the Bluegrass, we're the Bluegrass region. There are 15 area development districts around the state. So if you are here from another area, these are the 17 counties that we cover. But if you are either online or here and your loved one lives in an area outside of these counties, I can get you connected to the development district in that county, in that area of the state. And we all do similar things. We probably will all have a caregiver program and that kind of thing. It may just be executed a little bit differently at each district. And these are some of the programs and services that we provide through our agency. So the Aging and Disability Resource Center, the Senior Centers, Nutrition Program, Home Care, Nursing Home Ombudsman, Legal Services, our SHIP program, which helps with Medicare, health promotion and disease prevention, National Family Caregiver Support, which I will talk about in depth here in a few minutes, Medicaid waiver, our Kentucky Caregiver Program, and our Bluegrass Mental Health and Aging Coalition and Elder Abuse Prevention. Those are just some of our programs. And so you will hear me talk about some things today, and I have my card here, well, I'm not say that, but I have them over there. I can answer questions about programs and things like that. If you leave here and you think, oh, I have a question about this, I can answer direct questions, but for any program that you hear about today that we provide, you have to go through our Aging and Disability Resource Center. And that is the number and the email for that. So that is our That is our screening. So like I said, if you hear something, that you want to maybe get signed up for or learn more about, you would call that number. Now, that is the starting point for all of our programs. And so they receive a high volume of calls. So you may call today, leave your information. It may take a few weeks or a couple of weeks at least for someone to give you a call back. It's not necessary to keep calling them back every couple days. They haven't called me back and keep calling. That is not necessary. I know that's the nature to do that, but where they receive so many calls, it can take several days for someone to call you back. So what we like to tell people is leave a good contact number that where they can reach you. When they do call you back, please make sure that your voicemail is empty, because they will, if they do miss your call, they will leave a detailed message on who they are, why they're calling, and will leave a contact number for you to call them back. So please make sure. Another tip that I like to give people is once you've left your information, your contact information, you will probably want to go ahead and answer your phone until you receive that call back, because you may not recognize that number, but it may be them calling you back. And like I said, if you do happen to miss that phone call, they will call you back and leave a detailed message. So that's why that voicemail part is important. And then our elder nutrition program, that's one of our programs, and that is filtered through our senior centers. And this is just a little bit about our funding. We are funded through the Older Americans Act. So this is our National Family Caregiver Support Program. And this program is to support the caregiver, where a lot of the programs may be to help your loved one directly, like our Medicaid waiver program. That is so that they can receive their services. The goal is always to keep them home for as long as it is safe to do so. So Medicaid waiver could be a way for them to receive their services in their home instead of like in a nursing home. So they have to meet nursing home level of care and things like that. So those are like direct, you could get personal care and homemaking. Those are more direct services for your loved one, but this is for you. So this is the Caregiver Support Program. It provides up to $2,100 a fiscal year. So our fiscal year goes from July 1st to June 30th. So we are on our back quarter of our funding year, but we still have a couple of months left. I know we will soon start taking our referrals that we get. We'll just automatically put them on our next fiscal year because that's going to start July 1st. And we're kind of running out of time for someone to be able to use $2,100 of respite, but there in some cases, that it would still be possible to use that by the end of the fiscal year. With this program, you do have to reapply every year. And so we will be, if you are in our program currently, we will be sending out those applications to reapply late May. And so hopefully that'll give you time to get it filled out and send it back so that we can get you approved sometime in that fiscal year. It doesn't always happen that you're approved right in July, but you will be approved during that fiscal year.
Quick question.
Yes.
What types of things are they doing to use the funds? What types of things does that cover?
Okay, so it is a respite program. It is for someone to come and stay with your loved one while you go to the grocery store or, go to lunch with a friend or, if you have to go out of town overnight.
To pay for somebody else to come in.
Yes,
Okay. I know you're gonna get a massage that you need.
Yes, go get a massage. Absolutely.
I can go pay for my own. You all pay for
We'll pay for someone to stay.
That works too. That works too.
Exactly right, because we, just like Kelly was talking about the statistics of caregivers, we want you to take care of yourself so that you can be a better caregiver for your loved one. So I know sometimes it's hard to do and it's hard to think about, but just like being here today and getting this information is taking care of yourself. And that's number one in caregiving, is taking care of yourself so you can be a better caregiver for your loved one.
And just knowing that you're not alone, that's so
Absolutely.
important, that other people are going through.
Absolutely.
Which you know, but when you can hear and see others, it definitely helps.
And you can learn from each other, like some of these, tricks and things that, you may have used for your loved one that's, wandering, you may have a good idea for, someone else in the room to use.
Yeah.
So that, that kind of thing. So it's, wonderful that you are here learning some of these things. And like I said, you can learn from each other. Now, in addition to the respite, we have $500 to use for supplemental supplies, which could use incontinence supplies, which covers diapers, wipes, chucks, gloves, all of those products. Sometimes insurance may provide like the adult diapers, but they don't provide all those other necessary products. You can use it for like Booster Insure, if your loved one drinks Booster Insure, and some of the safety equipment like Kelly was talking about, the shower bench, the handheld shower, the things like that, you can use to purchase, you can use the $500 towards those types of purchases. And I will tell you the two ways that you can, once you're enrolled in our program, the ways in which you receive these funds is you can either choose to, pay someone like to stay with your loved one to provide that respite. And there's a little bit of paperwork involved that you'll receive once you're approved. You fill that out, submit that, monthly. We suggest you turning it in the month after you've used it because it is a lengthy process. We are dealing with the state, so we have to process it and it goes to the state and it can take several weeks to see that return. But that's why we kind of put that date on there. So if that's not an option, if you don't have, someone that someone close by that can provide that respite for you that you can be reimbursed for, you can use the agency that we currently contract with. We have a contract year every 3 years, and we just went through our contract year, and that contract was again awarded to Independence Assistance of the Bluegrass. So they are a local agency that provides the respite. We can pay them directly. So if you choose Independence Assistance, once you're approved, you're going to contact them, schedule that respite. They're going to send their care assistant out to your home and then send us the bill. So then you won't have that out-of-pocket expense, or the additional paperwork. And same for our supplies. You can order those supplies through Amazon. You can get them at Costco, Walmart, and you have to keep up with the receipts and do that little bit of paperwork and submit those to be reimbursed for that. Or we have two agencies that we can, you can contact them once you're approved, order the supplies. They'll send the supplies to your home and then send us the bill. So again, if you use an agency, that may be best for you for convenience. But like I said, if there's a certain product or a certain place that you like to buy those, you can do that reimbursement as well for either one. And so the funding is through the Older Americans Act, so it's not income based. You just have to be caring for someone 60 years of age or older or younger with a dementia diagnosis. So I have already covered all of that. One other component to our National Family Caregiver Support Program is that we do help grandparents who are raising their grandchildren. So, because a lot of times we do have someone who are taking care of their elderly parents and they're raising their grandchildren. And so through this program, we can also help them. And we do that by, we help with clothing, personal hygiene, school supplies, things of that nature. And if you know someone who you think would benefit from that program, please have them feel free to call me. So that was the state funded National Family Caregiver Support Program is federally funded. This is our state funded program, which also helps grandparents who are raising their grandchildren. This one is income based. And so the application is the referral process is the same. You would still call ADRC and then they would give us the referral and then we would send you that application. That is still the same, but there's a little more documentation you have to provide. Your income verification and proof of residency and custody of the grandkids, that kind of thing. So that one's a little bit more paperwork, but with that program, you're going to get $500 per grandchild to purchase those things And the national program is just $500 for the grandparent to purchase those. And then this is our Medicaid waiver. I talked about that a little bit, where you can get your services for your loved one in their home. And this is some of the eligibility for waiver. This process is a little bit more complicated than my process. Typically with mine, you fill out the application and send it back, and usually, especially this time of year, it doesn't usually take that long to get approved. But this program has a lot more components and is a little bit more complicated, but our ADRC can help you with that. Like I said, these are just some of the other programs that our that filters through our agency. And so this is our elder abuse, how to report elder abuse. So that's the number that you would call for that. And then these are some of the other programs that we offer. And a lot of times these programs are, you can receive these programs at our senior centers, or A Matter of Balance. I think Drums Alive is a very popular program, Tai Chi, some of those things. And then our Bluegrass Mental Health and Aging Coalition, I know that we have, they put on a conference every year in Clark County, and that is going to be held this year in June. I'm actually speaking at it, and I can't remember the exact date. The 26th, thank you. And so that is June 26th, and that is held at the Extension Office in Clark County. And this is our home care program. So our home care program is another program where you can receive your personal care and homemaking and things like that in your home. It's a little bit different than eligibility than the Medicaid waiver, but that ADRC specialist, when you call, they will go over those options and let you know what your loved one is eligible for. And this is our Facebook, and we do put out a monthly newsletter. And then this is my contact information. That is my direct number. That goes directly to me. If I cannot answer your call immediately, then please leave me a message, and I do my very best to return phone calls. So I do want to talk to you a little bit about some of the things that I have brought. Kelly mentioned these cards, the Dementia Friendly Lexington. On the front of this card is a QR code that is going to tell you all of the businesses that have gone through the training and are dementia friendly, like some of the restaurants. I know that they have trained some churches. Real estate agents have gone through this training. And so that QR code will help you know which businesses have completed that training. Our agency has completed that training, but then on the back is that helpful, card that you can just discreetly hand to someone that says, please be patient. The person with me has dementia or Alzheimer's disease. Thank you for understanding. And I know that I went thoroughly through our National Family Caregiver Support, but I did bring some brochures if you would want to take those with you. So a few years ago, the state developed the Office of Dementia Services. And through that office, they realized how important that services for people with dementia and their caregivers are. So they developed that office. And through that are some of these dementia care services. I am the dementia care specialist in this area. There's one in Pennyrile and Buffalo Trace. And so this just talks about some of the programs that we offer. Now, they applied for a grant, and that grant does end June 30th, but there are still some funds available for that. And when they started that grant, they started it off being modeled after Medicaid waiver, and then they realized that they weren't getting a lot of participants because that's such a complicated process that by the time that they were getting Medicaid waiver, by the time they were getting the Bridging the Gap program, they could have gotten Medicaid waiver. So now they kind of revamped that, and now it's more of like an extension of our caregiver program. And so, the process is similar as National Family. We do only have a couple more months left to use that, but with that, it is additional respite. It is $4,500 of respite and $500 for assistive technology. Like Kelly was talking about, some of the gadgets and some of the things that you could purchase, like the automatic the pill dispenser and the motion lights and things like that. There are still funds available with that program where you can purchase some of those things. And then I wanted to talk about this flyer that you have. And through our Office of Dementia Services, I was able to be trained at a program called Dealing with Dementia. And that I was trained through the Rosalind Carter Institute. And this is a wonderful program. We have the next one coming up May 23rd. It's going to be at our office. Pre-registration is required. I try to keep the number small just because so that you can share and learn from each other. And with this training, I didn't bring it with me, but you're going to receive it's a huge book. And the purpose of the training is to teach you how to use the book, so that it's not, I'm not just handing you this gigantic thick book and saying, here, hope this helps you. So the training is to show you how to use, and we go through, the book and just show you the elements of it and how to use it. It does in detail. There's several chapters about the behaviors that we've talked about today and some of the techniques and some of the things that you can, try to use to navigate through those. So it's a very useful book. At the end, you do get to take that book with you. Am I running?
No, we just got a message saying they can't see the slide. So.
I'm just, this isn't on a slide.
Okay.
This is just
I'll
a
let them know.
flyer.
Okay.
Yeah, I'm so sorry.
No worries. I just got the message. It says screen sharing's paused. Up top.
I think it's because that's the end.
Oh, okay. Could be.
Yeah, I think it's just because that's the end of the slide. And I'm sorry for the people who are online. I am just talking about a flyer that I have. It's not on the screen. If you are interested in receiving this, Meredith, could they send their email?
I said we can send the flyer out.
Send the flyer out.
And everything else.
Okay, yes, when they send out the PowerPoints and things like that, I'll have Sarah send this out. But this is going to be May 23rd. By attending that workshop, that book is yours. I mean, when we go through it, we want you to highlight it and write in it, and we want you to be able to use it. It's a wonderful resource guide. But it is 4 hours long, which I know is a long time. We do try to get a lunch sponsor because it's from 10 to 2. And so if you are able, and this is something that I'm hoping, even though the Bridging the Gap funding is ending June 30th, we are still planning on utilizing the dementia care services. And I hope to be able to have these classes more frequently. I'm planning one now to have in Frankfurt. I've had one in Clark County. So my goal is to go to all the rural counties and then still have this at our agency as well. And then we talked a little bit, they've talked about advanced care planning and things like that. And I know that's a very difficult conversation, but this is a flyer about a product that we learned about at a conference a few years ago, and it's called Honor My Decisions. And this is, you have to have an activation code, which we have purchased. So if you are interested in this, you would contact Celeste Robinson. She is the Director of Aging at our agency, and she will provide you with that code. But this is like an electronic, a digital advanced care planning, so that you don't have to keep up with the papers and things like that. This is digital, where you log in, you create a password, and you can access that, if you're in an emergency situation at a hospital, and you can, have access to that digitally. It's gonna maybe be more convenient for you, but like I said, I have the flyer here, and we will I'll have Sarah email that out when she sends the others. And then this is another type of advanced care planning. This is the paper. This is called 5 Wishes, and so I have these here as well if you want to take that with you, so that you can just go through and kind of. But this is a paper that you would have to keep up with. But so I just wanted to take the opportunity to give you all some of the local resources, and in addition to the Alzheimer's Association, which is a wonderful resource as well, and Sanders Brown. These are just some of the caregiver supports that we have locally and in the 16 other surrounding counties that we have. I know I gave you all a ton of information. Does anybody have any questions? All right, well, thank you so much, and Diane. I think you're. And I'm just gonna.
Before I get started, my background a little bit, I actually, back when the dinosaurs were still on the earth, was here at Sanders Brown and the chemistry department, got a PhD here at UK, and my research through the chem department was about Alzheimer's. But I always hoped I never have to deal with it, quite honestly, on a personal level. What does life do when you decide you don't want something that's going to kill you?
Yes.
So my husband has something called Lewy body dementia. And I bring that up because I'm not talking theoretically. I've walked where you're walking now. So I want to put in a plug for social workers, because the physicians are there to take care of your loved one. The physicians aren't there to take care of us. And just when I thought I didn't know what in the world to do, they referred me to a social worker who gave me information and support that was really important. So I hope you avail yourself of the social worker support, for example, that Regina was talking about. Because my husband had a different kind of dementia, I'm also going to mention in this some of the things you will see with other kinds of dementias besides Alzheimer's. Is anybody aware that they are dealing with a different disease than Alzheimer's? Sometimes in these workshops, we will get people like that, but I'm going to mention it anyway because it's often not talked about enough, and the diseases are not the same. They show up differently, and you will see different things with different diseases. Let's see if I can figure out this technology. No. Down here?
Yeah, usually it's like a
There
minute,
it
but
is.
it's kind
Well,
of weird how it's.
Regina said when she pushed this for hers, it worked.
There
Okay,
we
I have
go.
to use this one. Alzheimer's Association,
Okay.
Alzheimer's Association program.
There we go.
This is part of a larger program that the association does. And I was speaking with someone during break. If you will watch for the references that you're being given today, the association offers a number of 1-hour workshops on different practical aspects of dealing with dementia. And the one that we're going to do today is the one called Communicating Effectively. But you see that there are others that may be of interest to you. All right, I'm going to fight with this mouse. I do not read slides to people. You're all perfectly capable of reading slides on your own. This is about communication. They're going to talk about something called person-centered care. Is this a familiar phrase? It really is kind of a sensible thing. What it means is you're going to care for a person specific to that person. So you've got to kind of know that person in order to really provide good person-centered care. There will be some strategies about helping you learn to some techniques for communicating. And at the end, I'll talk about some ways to communicate, not just with the person who has dementia, but also with family, with other caregivers, perhaps with professionals. You didn't know you were going to have an exam, did you? We all know what this is. You know, this part. We don't think about the definition, though. When we communicate, we might want to be doing a number of things. We might want to be telling people what we need, what we want. They mentioned previously that some of the behavior difficulties are because people get where they can't communicate. For example, I'm hurting. I have to go to the bathroom. They don't know how to say that. And so we have to find ways around it. Sharing thoughts and feelings. also that becomes more difficult as the disease progresses. And it is a way of connecting to each other. We're connecting today mainly through words. As the disease goes on, that becomes a less and less effective way to communicate. So they're going to mention some other things you should keep in mind as time goes on about communicating. Another test question. You get to pick two. This is not even a tough multiple choice. Come on, we can do 2 out of 4.
All the above.
Yeah, sure. And I think I have to click on this.
Yeah, you have to.
Before it'll let me go. We all know this. Anybody else in here been a teacher? Okay, I'm in your class.
A communication class of all classes.
My communication teacher, yeah. Do I have to say? I mean, we're teachers, we've seen it. We know teenagers and the proverbial eye roll. This is really important because as time goes on and they become less and less able to communicate with words, it's more and more important that we keep in mind our body language and our facial expressions and our nonverbal communication. So this is more important than it might appear at first. You've already heard a lot about what dementia is, so I'm not going to talk about this anymore, except to say it's not the person anymore that you knew for however many years. The brain is being destroyed. They can't do things the way they used to do them. It's not that they're trying to be a pain in the neck. Are we going to the doctor today? Are we going to the doctor today? Are we going to the doctor today? Anybody been through this routine? And after the 15th time, they're not doing it on purpose. And we have to remember it's the disease that's doing this. It's not the person that we knew. And this is a list of some of the things that you might see with a person who has some kind of dementia. You're going to look at some of these and say, oh my gosh, I already do that. There are changes that take place in our brains with normal aging. And they've already mentioned some of this, some of the slides with graphs on them. We are more slow as we get older to remember words, for example, but it's exaggerated. What I always kind of tell people is this. Think about a couple of things. One is this really different than the person was before? And does this interfere with the person's ability to live independently? Now, if I've got a word on the tip of my tongue and I can't remember the movie star who was in that cotton picking movie, so what? Okay. Consider those things and consider context. If the person goes to the doctor and has to think for a while about what their address is, you see we've got a different story there. Okay. We've already talked about the repetition business. This can be, anybody got funny examples of this one? When they can't think of the word for something, they'll describe it. One funny one somebody told me was, couldn't think of what a puppy was. So it was a dog kitten.
Oh.
Yeah. Well, okay. I mean, we get the picture. I know no one in here has ever lost track of what they were saying in the middle of a sentence. How often does it happen? And,
Or forgot what they walked in a room for.
oh, man, if that is a symbol of dementia, we all got it.
Exactly.
And you know what else? Did you think you ever did that when you were 25? That you walked into another room and forgot what you went in there for? Yeah, you did.
Yeah.
You did this when you were 25, but when you were 25, your first thought was not, oh my
Yeah.
God, am I getting dementia? You didn't pay attention to it, you just thought, well, yeah. And it went on. So a lot of what we might see in normal aging, some of it has always been happening, we've just not paid a lot of attention to it. Word organization, making good sentences. Going back to speaking in their native language is an interesting one. Less often and hand gestures. I'm going to mention here, one of the kinds of dementias is called frontotemporal dementia. This is a different disease. Usually strikes people when they are somewhat younger. There was a person in the workshop last time whose wife had this, 54. And their memory's fine. They recognize people. They can't speak properly. And they sometimes can't understand words. And that's a very unique and special thing for this frontotemporal dementia.
What does that mean they can't speak properly? Like what would?
It's in their heads. They can't get it out. There's nothing wrong with their mouth or jaws or throat or anything. The part of the brain that's responsible for generating speech in particular is being destroyed. So they will see a picture of something and they might know what it is, but they can't get the word out.
I'm sure this isn't a new one, but it seems like this is a more prominent one that we're hearing about now.
Well, it is for two people reasons. Who are the two people? Anybody know?
Bruce Willis and
Bruce Willis. Wendy Williams.
Wendy Williams, yeah.
That's why we're hearing more about this. And for better or worse, so many diseases, when a celebrity gets it, we start hearing about it. And frontotemporal is one of those. So that's a special problem with frontotemporal, along sometimes with really, really off the wall behavior.
Do those particularly strike earlier in age? Is that what you said?
Frontotemporal typically strikes earlier.
Okay.
Yeah.
Do they know why?
Nope. I mentioned person-centered. Example that I liked of this one was a person told me once during a program that their grandmother collected wheat pennies. Now, the youngins in here, if there were any youngins, I don't know what
I know what those are.
wheat penny. What the
Yeah.
heck's a wheat penny?
Wheat penny.
Well, some of us know very well what a wheat penny is.
Mhm.
Pennies used to have not the Lincoln Memorial, I think, on the back of them, but grains of wheat. And her grandmother had been a coin collector and just loved wheat pennies. So when the granddaughter would bring her some wheat pennies, she was delighted. Would that work for your grandmother? No, probably not. So I thought that was a really great example of knowing the person and interacting with them in a way that is person-centered. Some general hints. Treat everybody with respect and dignity, but especially people who have dementia, because so often we think, oh, they're gone. They don't know what's going on. They're not there. We can say or do anything we want. Not true. Call the person by their name is one thing. This is a big one, the third one. I did a presentation at a facility once, and the staff manager said, address that in particular, because I've seen so many staff members who will talk to another staff member in front of the person who has dementia, like they were totally ignorant and couldn't understand a thing. He said that's gotta stop. So, don't do that. And if you go to the doctor with your loved one, I bet most of you have experienced this. Sometimes the doctor, who do they talk to?
My mom. She talks to my mom. My
Okay.
doctor's, her doctor's really good. She'll talk to her instead of us.
Really good.
That's
That is
excellent.
good. That is good. I appreciate
But
it.
very often,
They talk to
they will talk to the caregiver.
Don't talk to the caregiver, but you're in a confined space, so you're gonna be talking. I
Oh, I
would be
know.
uncomfortable with that with my husband. He was a veteran and the VA doctor would ask questions and he's sitting right there.
Yes,
Yeah.
you.
And I didn't know how he was gonna process my answer, you know what I'm saying?
Mhm.
And so it was a weird
Yeah, it
dynamic in
is.
that exam room that did,
Can I just interject really
Yes.
quickly? During that time, it's really good to write down, like maybe write down and have it printed out or handwrite it. The things that you're concerned about, that you don't wanna talk about in front of your loved one. And when you check in, slip that letter
Oh,
to the
that's
nurse.
That's a good
Or
idea.
Really good idea.
That's a
The
good
check-in
idea.
person, so the
Yes.
doctor can review it or provider can review it before they get in, so they can get a jump start on what you're seeing at home, because so often we see that here. They can't talk about it in front of their loved one, because then they're gonna get yelled at when they get back in the car.
Yeah.
And everybody's adrenaline is kind of on
Yes.
point when they're at
Yes.
the doctor's office, so they're gonna be a little bit sharper and they're gonna know the answers a little bit better than they might do on a day-to-day. So what the physician sees might not be what the actual case you see at home is.
See, I tried to adapt my words accordingly so that it wouldn't set
Right.
them off.
Yeah.
That I would try and communicate, get the point across to the doctor, But yeah, that's a good idea.
Sometimes I stand behind or sit really just right behind the person that they should be talking to, so that they can kind of make eye contact with us both.
That's good.
He's a little bit like.
And I
"What are you
tried
doing
so
there?"
much with my eyes, like,
Yeah.
every kind of facial
But then you
expression.
can't really
Doctors
speak
can- you can speak freely,
Honestly,
yes,
and
yes.
yeah, you wanna make sure that what you're saying when you're there is what's accurate.
And this is an excellent point. If they will let you go into the doctor with them, do it. You may have heard this phrase, at least with Lewy body, we use it a lot. There's good times, there's bad times, and then there's showtime. And when they go to a doctor, or in my case, when I would take him to visit his adult kids, I mean, they could act like they didn't know which end is up at home, and you get them to the doctor.
Yes.
And they just, they really perform well.
And you don't know what's gonna come out of their mouth. I'll share the story with you guys. My husband had a lot of health issues. I always teased him and told him that he went to the medical supermarket, said, I'll take this and this. But I would always, when we would get reports that were challenging, I would say, I would remind him, we are a team. We are a team. I don't know where this came from, but I took him to the doctor. He's sitting on the exam room table and there was something that the doctor said and he it just out of the blue, he goes, well, she always says we're a team. She's the brains and I'm the beauty.
That's great though.
I don't know where it came from.
One thing we all have to do, even though this is very serious and difficult and the hardest thing I ever did, you gotta laugh.
Yes.
You gotta laugh sometimes. So wherever you get the opportunity, definitely take advantage of it. The part about correcting them, one of the things that happens with Lewy body is right up front, hallucinations and delusions. And, dumb me, I did everything wrong, so I can make fun of this because I did it all wrong.
Yeah.
Yeah, the scientist here. No, there's no puppies in the corner. You're hallucinating. Now, hallucinations are caused by. And, I came out of the shower one morning and he's sitting there with a gun in his hand, picking up on the safety stuff. There's somebody in the shower. Well, yes, that would be me and.
You might flip her.
And so, if you're dealing with Lewy, you're gonna have different kinds of neuropsychiatric symptoms right from the get-go that you need to learn how to deal with. And one of the big things is don't confront. Because if you start arguing with them and telling them they're full of it, all that's going to do is make things worse. And I did a lot of that. So I wish I had known not to.
It's hard not to.
It's
That's
hard
where
not
we're at
to.
right now. It's like, oh, I
And
can't
you
stand
know,
this.
one of the other speakers mentioned maybe kind of not telling them the truth. We call that sometimes compassionate deception or therapeutic fibbing.
Yeah.
And sometimes that's the best thing to do because you always want to de-escalate. You don't want to spin things up. The business about validating their feelings. One of the things I think about communication is try to put yourself in their shoes and imagine what they are feeling. Some of the other speakers talked about fear and wanting to go home and just not understanding what was going on. None of us wants to be quote unquote blown off when we express feelings to someone. So if you come in and they're saying, my purse is gone, someone stole my purse. And your response is, oh, for God's sake, it's right there in the corner. Can't you see it? You see what you're communicating? Not just with your words, but with your body language and with your facial expressions. You know, you're not validating their feelings. So maybe a better response to someone stolen my purse is think about how you would feel, not you, but if someone stole your purse. I'd freak out. So, oh my goodness, that's terrible. Let's look for it in the house. And then, you know, if it's not here, we'll certainly call the police. And then you look for it in the house and you know, you're going to find it. Oh, good. I'm so glad we found it. So take that approach rather than trying to argue or ignoring what they.
Can I just ask a quick question
Yeah.
similarly? So like with my mom, she would always accuse my sister of taking her clothes. So she called me, she has my clothes and she won't bring them back. And in the beginning, this is about a year ago. So I'll be like, mother, you know she doesn't have it. Why? And I would just keep doing it. And then she would say things that would be, you know, off the wall accusatory. And I would just like, I would badger her. But I was like, Mom, you know. And then I finally heard that it's not a good thing to do that. But I just don't really, I'm like, when you know they're wrong, like, can't you? I didn't want her to keep saying, that Sheila has my clothes, Sheila has my clothes. So I wanted to sort of come in and step in and, so should I have just let her keep saying Sheila has her clothes? See, I couldn't deal with it. That was
It's everything.
girl is still in my clothes. I didn't want that for my sister
Or
who
maybe
takes
like,
care of her most of the
well, let me
time.
call, I'll call her and tell her to bring it back.
I did that.
You know?
Yeah.
And that was okay,
Uh-huh.
but she still kept telling people that so I was like, oh, I just don't want to give in to saying, yes, Mom, I know Sheila has your clothes, I'm sorry, I'm gonna tell Sheila to bring it home.
Yeah. I'll tell her
That was
again.
hard for me, but I found.
It's the repetition thing.
Okay.
Mhm.
Does it make us crazy to keep on having to do that? Yes. It's not about us anymore.
Right.
Okay, there we go.
It's about
making her.
Well, and can I just interject?
Yeah.
It's about meeting them where they are. If she believes that, you just gonna have to meet her there. And another piece of advice, you're probably never gonna win that argument, so just don't argue with them.
Because then it just
Meet
makes
them
you
where they are,
upset,
and
and
like you
we're
said, just
upset,
come
so
up with
if you
some-
just.
Yeah,
meet
think
her
about it as
there,
compassionate
then,
deception.
Mhm.
Yeah, okay, okay.
It can
I
make
just
it
wanted to make
it's
sure.
so hard though.
It is hard,
Yeah.
it's very hard.
But if it can
Oh.
you call her, you like, yes, Mom, I'll call her again and tell her to bring it back, or, I mean, you might be repetition to even do that, but then you're not, you know, in this battle with her, and she's not in this battle with you, right?
Yeah.
And everybody's emotions can be kind of, yeah.
The people around my family, they know what's going on.
Yeah.
They're So
it's
so gentle, and I try and kind of encourage her, tell them some of the things that work and some of the things that happen, and they give that back, which has been great. So like the calling and complaining about the relatives, like Yeah, but they know it's not true.
One of the other speakers also mentioned, one of the first things they will often try to tell you to do when you're dealing with some kind of problem behavior is distraction. You could respond quickly to that and then try to distract to some other topic. And in that way, you sort of use the memory loss to your advantage, if you will. Because if you can distract them for a little while, maybe they'll forget about that problem and go on to something else. And this is
That
a,
didn't work with my father, he'd tell me that's bullshit.
Oh, wow.
Dad had a great set of words.
Words. You didn't even know they.
I said, I know.
You never seen colorful.
Yeah.
Yeah, the real person for real. I mean,
language changes can also be quite interesting in some people who've been very good church going all their lives.
Actually,
And now all of a sudden they're got a sailor vocabulary.
Yeah.
She's the sweetest little demure woman. I took her to church one day and there was a gentleman in front of us that had a long ponytail. Arlene, I wish I brought my scissors.
This is the kind of thing though, does it rip your heart out? Yes.
Yes, because it's so not, no way.
Because it's so not them.
It's so not them.
But do you have to laugh in some ways, like we're laughing at it now? And it's good for us to laugh. So,
Yeah.
we could all come up with some great stories, I'm sure. We've already kind of addressed this one. Don't pretend they're not there. They may not be able to communicate the way they could. They may not be able to understand as much as they could. But do everything you can to include them. And that generally means keep things as calm and quiet as possible. Connect with them with body language, with eye contact. Several speakers have also mentioned short-term memory is the worst affected, but they probably will remember 50, 60 years ago.
Yes.
Talk to them about that. If that's what works, that's what works. This one is a tough one. As we kind of had talked about already, the 15th time they'd ask you the same question in a row, it's really difficult to be patient. Maybe if we keep remembering that business about their brain is dying. You know, if a person that we knew was a double amputee, would we get annoyed because they couldn't get up and walk and go get us a cup of coffee? Well, no.
Good enough.
That we wouldn't. When we can see a physical problem, we are more understanding. But when we can't see the problem, we're somewhat less understanding. So try not to speak for them. In the early stages, if you can have one of these difficult conversations about what do you want me to do? Do you want me to help you find your sentences? Would you rather, look for things on your own? If you can talk to them about things like that early on, sometimes it's too late for that. But if you finish their sentences and they get annoyed, that might tell you maybe they want me to just give them choices, but not too many. If you make questions too open-ended,
What
it's
would you
not,
like for breakfast?
yeah, oh my
And I
gosh,
had to twist it. It took me a while. I was on a learning curve.
there you go, choices, yeah.
Your choices are this or this.
Yeah, a cereal or a biscuit,
There you
or
go.
whatever it might be.
Yeah.
So give them some choices, but don't make it too extreme. And we hear a lot about mindfulness and living in the moment and all that sort of thing, and you definitely have to do that dealing with a person with dementia. Distractions. There's a funny meme I saw not too long ago, and this is for those of us who are older. And the meme said, "One day you're young and fun, The next, you're turning down the music in the car so that you can see better. Now, some of you youngins won't appreciate that, but some of us do. And certainly it's extra true for people who already have cognitive functions. Time and place to have a conversation is not to take them to a noisy restaurant. Not when there's a TV show on. Maybe a couple people, but probably not a whole lot more. Think about Christmas get-togethers. Suppose my husband had 8 siblings and 30-something nieces and nephews, and OMG, when the whole gang got together, I found it just crazy. And it was his family, but even so, 45 people in a place, all talking, eating, carrying on, it can be pretty overwhelming. Put away the phone. And we've already kind of talked about this one. Be real conscious of nonverbal. They're going to understand that long after they understand any words you say, or long after they can say anything. You'll be able to communicate that way. The sight, touch, sounds, that's been mentioned by another speaker. Particularly in the later stages, they will tell you to communicate with senses. For example, gentle touch. Something visual that's pleasing but not overwhelming. Bright and colorful but not kaleidoscopic, perhaps. One thing I might mention about smell and taste that will work for some people. One of the things that often happens for Alzheimer's and Parkinson's too, I might add, which is a form of dementia. One of the earliest symptoms can be loss of sense of smell. So taste and smell may be less and less appealing for them. You can try it, again, depends on the person. And I'm going to skip the caregivers because I'd rather hear from you. And I'm going to skip Alonzo if I can. Yeah. Okay, we have to do it. 2 choices. What should he do? Put on the radio as loud as he can. No. Hold his hand and read a book.
Mhm.
And then I have to submit these answers and see if we got it.
See if you passed.
Yeah. This next section has to do with other people. Any comments, questions, stories about communicating with the person that you're caring for? Suggestions for communication. And you already know that unlike chemistry, which is what I taught for 50 plus years, chemistry has an answer. If I gave a problem, by golly, that's the answer I wanted. Dementia.
Want the instruction book.
I wish there were an instruction book. What works today might not work tomorrow. What works for your loved one, my loved one might hate. It's that person-centered care business. So don't be surprised at that it's not as easy to care for them as it is for a person with another disease that's more predictable. I found that very difficult. If you've got a person with cancer, for example, they're with you and you are tackling the problem together. But as time goes on, with dementia, they're less and less able to be there with you. Comments, questions? This next part, I'm going to go through pretty quickly. Don't isolate yourself. And I'm going to laugh at that. Because what happens, especially if you're living with the person, if it's your spouse, for example, or you're living with the person you're caring for, what tends to happen to you? you get isolated. And you know what else tends to happen, and I would bring this up with family and friends. When there's a person with dementia, what tends to happen to their family and friend visits?
Gone.
Yes.
Try to encourage their friends and family to come and visit them. I saw a big problem with this. And what you might hear from friends and family is, oh, it upsets me too much. And what I want to say is, tough. Oh, it upsets you too much. And I can't have a sensible conversation. It doesn't matter. What the person will know is somebody is there who cares about me and wants to talk to me and will spend a little bit of time with me. And maybe they will remember who it is and maybe they won't. But, oh gosh, the isolation really can be a significant thing. So I would strongly encourage your friends and family not to abandon them in this time of great need. The professionals, it was already mentioned, prepare for appointments. If you write things down, even write down your observations of what you are seeing. Because going along with showtime, we would go to the neurologist and the neurologist would be talking to John and John would be answering him and I would be sitting in the back going.
Your head's on a swivel. But like,
No.
Not.
And it's, you know, that is their perception of reality. Remember what you've heard several times today. People don't always know that they have cognitive problems. So if you can keep specific notes, it also helps the physicians with diagnosis. For example, for me, when I was observing hallucinations, delusions, that's not typical for Alzheimer's in the early stage, or for frontotemporal in the early stage, or if I'm finding that they're getting lost often, or has anybody had the experience of having their loved one draw a clock face? And they can't draw a clock face even though they have an IQ of 150.
What's the new generation gonna do?
They
They
won't
don't even know what a clock face is.
That sounds like a good PhD research project, is to come up with a replacement test for visual
Yeah,
spatial
it's gonna
skills.
be, right?
Yeah. So that one kind of, I think, is apparent. And I'm sure Meredith has included here or brought much information. The Alzheimer's Association has an office locally. They can be a great help. They offer many programs. So call Meredith.
And she'll email you back.
They also have online support programs if they're not able to get out and about. They're really great. They're in every state. There's a chapter in every state. And they do a ton of funding on clinical trial drugs that are anticipated to work, so.
I strongly encourage the support group for the caregiver.
Yeah.
Are there like any that are larger? So we've taken my mother-in-law to a couple of support groups and well, 3, and mainly it's just 1 or 2 people, which isn't helpful.
Right.
You know, the
I know.
biggest one we found right now is the Fayette County, I guess Fayette.
I'm gonna direct that question. Meredith, do you know size of support groups? Are there any that where more than 1 or 2 people will show up? Yes.
Yes, the Fayette County Early Stage Support Group usually averages 30 people. Carla's Caregiver Support Group that's out at our office, she usually has maybe 12 to 15.
Yeah, I think we've been going to.
It's in the basement of the
Yes,
Alzheimer's
that's the
Association.
one
Yeah.
we've been going to that has more people.
Yeah, that one has the most, and then there's one at Bridgepoint that Taylor
Right,
County
that
was,
only has.
and that only has like 3 to 4 maybe.
Yeah, we've been
Yeah.
there.
I would also say if you're in Lexington, Memory Cafe, Sarah and Meredith run an incredible program with Memory Cafe. And it's just socialization, but people with disease, we've got a lot of moderate to severe stage of disease in that group and caregivers, and it's the funnest day of the month.
It
I
is,
think,
It is so
personally.
fun.
it's amazing.
Okay, so how do
So,
I find out about that?
Sarah's gonna send out the slideshow that was at the beginning, and it has our information. I can also. So,
Okay.
Are you aware of like a camp, like a residential where you could go away for a long weekend or a week?
They have respite care at all of the facilities around town. It's kind of like their way of introducing you to the facility before you, I mean, it's a marketing ploy, but it's really great for caregivers. We had a caregiver that was able to go on a trip with her daughter. Typically, it's 1 to 2 weeks, so it can't be like 3 or 4 days, but any facility should offer that.
But literally a camp where you're outside.
No,
There's no
I don't know
camps.
if it's
Like,
There's like a daycare.
yeah.
Don't forget about your national family, they can help pay for those residents.
Yes.
Some volunteer.
And I think I'm gonna make the 12 o'clock deadline. Whoever's gonna finish up here, thank you all for your attention.
Thank you.
Thank you.
Yeah, so thank you all so much for coming. Please take a book, help yourself to a couple for your sister as well.
Thank you.
We've got more information of what Regina handed out right here. And then if you should get the emailed slides after this program.
Now that will be, please make sure we get those
Yeah.
slides. I've already told them slides are coming.
She keeps us all in line and in check, so she will absolutely get those out for you. But yeah, and think about the programs that people were talking about today. They're really, really helpful.